Hello, hello. Yeah. Thank you, Steffi, for this extraordinary opportunity to be able to, chair and even attend this, important conference about lobular cancer. So kind of an orphan for a long time. And it's very nice to see everybody taking this up and fighting against and trying to figure out how best to manage this breast cancer and not just treat it as IDC. So thank you so much. I just did notice, though, that you had a little tricky thing there. So knowing that I'm a medical oncologist, you asked me to chair a surgical oncology thing. So that's great. Yeah, well, I learned some more things last night. So thank you for that. So I'm from Ohio State University. I'm a medical oncologist, and I also do research on ILC. I have a lab. So those are my interests, and looking at resistance and dormancy and things like that. So we are really delighted to have today two important questions, I think, in the surgical management, and I'm glad you brought this up in the, as a topic today. One is the surgical management of ILC, the challenges and the opportunities, and I'm very happy to welcome Dr. Rita Mukhtar to give the talk, and I'm excited to have her talk about this and ask questions. So it's great. Thank you so much.
Good morning. Can you guys hear me? Okay, great. Okay. Thank you so much for the opportunity to speak about the surgical management of ILC. I wanted to talk about surgical outcomes for patients with ILC. I'm going to also review some of the data on preoperative breast MRI and planning surgery. And then I'm going to share some of our institutional data on surgical techniques and the safety of various surgical approaches for patients with ILC. I thought that I would start with an example of a patient. The patient is a 75-year-old healthy woman who had a screening mammogram that identified a mixed lobular ductal cancer in her left breast. The right mammogram was negative. She then had a breast MRI, and on the breast MRI, the tumor on the left side did show up as a small area of enhancement, but in the opposite breast, the right breast, there was this abnormality, and this is called non-mass enhancement. So this bright area that's forming not exactly a well-circumscribed mass, and this measured 9 millimeters in size. It was not visible on mammogram, was not visible on ultrasounds. So she had an MRI-guided core needle biopsy that showed ILC. She then had partial mastectomies in both breasts. The left side, which was the side that was found on mammogram, the tumor measured 6 millimeters and had a large area of LCIS. And the right side, which was this 9 millimeters, can anyone guess how large it was on pathology? Okay. It was 4.5 centimeters on pathology. She had positive margins. She went on letrozole for a few months before having a re-excision. The re-excision showed two additional foci of ILC, one measuring 1.6 centimeters and the other measuring 6 millimeters. Both had positive margins. She then decided to have a completion mastectomy, had a nipple-sparing mastectomy that showed an additional 4.2 centimeters of ILC. So this very recent patient really exemplifies some of the challenges that patients with ILC face when it comes to the preoperative evaluation and local therapy. So she had a tumor that was mammographically occult, meaning did not show up on mammogram. The MRI significantly underestimated the tumor burden in her breast. She had positive margins, and she had to have multiple operations. And this is really supported by the literature that patients with ILC do indeed have worse surgical outcomes compared to patients with invasive ductal carcinoma. And by worse surgical outcomes, we're talking about higher rates of positive margins, higher rates of mastectomy, and an increased need for axillary dissection. And we'll be hearing more from Dr. McAuliffe about axillary dissection for ILC. And some of the reasons for why we have these disparate outcomes between ILC and IDC include the fact that patients with ILC do present at higher stages. We see higher discordance between the clinical stage and the pathologic stage, and this is likely related to the lower sensitivity of the standard imaging tools that we use when diagnosing and staging ILC. Many series in the literature demonstrate that when you compare the rate of positive margins in ILC compared to IDC, that across the board, you'll see that the patients with ILC do have higher rates of positive margins. And having positive margins has significant negative consequences for patients. So positive margins and having a re-excision are associated with significantly lower rates of breast satisfaction and sexual well-being. Having to undergo that second operation does confer a higher risk of surgical complications such as infection, seroma, hematoma, and fat necrosis. Having those additional operations are associated with significantly increased healthcare costs. And if those positive margins are not addressed surgically, there is an increased risk of recurrence. So should patients with ILC always choose mastectomy? Well, mastectomy may be the right choice for certain patients if that's their preference and depending on their personal situation. But the data don't support recommending mastectomy for every patient. We have many studies that include huge numbers of patients that show that the outcomes between breast conserving therapy and mastectomy are the same or possibly even better in terms of overall survival for patients who have lumpectomy and radiation compared to mastectomy. Additionally, if a person has a positive lymph node and undergoes a mastectomy, their local regional management can be complicated because post-mastectomy radiation may be recommended, axillary dissection and nodal radiation may be recommended, and this can have implications for any reconstructive procedures that the patient might choose to undergo. And the more local therapy that we do in terms of more extensive surgery, the more complications that patients will get. And we may hear more about this later, but we know that doing more local therapy can increase the risk of lymphedema. And I'll show you a picture of a patient with lymphedema on the next slide. Patients with ILC are known to present with higher rates of nodal positivity. And in one large study of 692 patients, of those who were clinically node negative, meaning there was no indication of nodal involvement before going to the operating room, about a quarter of them actually had a positive sentinel lymph node. And again, this is reflecting the fact that those with ILC are more likely to be upstaged than those with IDC, meaning once you do the operation, you find that in fact the stage was higher than what you thought before surgery. This is a photo of a patient who had a mastectomy and an axillary dissection, demonstrating one of the consequences of doing this sort of extensive local regional therapy. And this is lymphedema of the left upper extremity. And this can be a chronic condition, as many in the audience probably know. If someone has an axillary dissection and radiation, the risk of developing lymphedema is actually 30 to 40%, so not insignificant. So again, I'm going to be sharing data on how we can potentially use breast MRI, and is this the answer for improving our surgical outcomes? And then I'm going to share some of our institutional data on margin status, the management of those positive margins, and the safety of different types of surgical procedures. So for breast MRI in the preoperative evaluation of patients with ILC, I should disclose that I do obtain and recommend breast MRI for all of my patients with ILC. But if you look in the literature, the data don't necessarily support this. The data are from single institution retrospective series, and the results are actually mixed. However, there is data that breast MRI has higher concordance with pathology size than conventional imaging. So these plots, this plot here is a Bland-Altman plot, and this is looking at how well does the imaging study determine the size of the tumor compared to pathology, with pathology being the gold standard. So on the x-axis, you have the size of the tumor on pathology, so the true size. And then on the y-axis, you have the difference between the size on mammogram and ultrasound compared to the size on pathology. So you can see here that for tumors that are less than 2 centimeters in size, mammogram and ultrasound didn't do so badly. So the difference in size is close to 0. So the size matches up. But once an ILC tumor is larger than 2 centimeters, you can see that for a lot of patients, mammogram and ultrasound significantly underestimates the size. So this patient here, their mammogram and ultrasound underestimated the size by about 5 centimeters compared to pathology. In this study, they also looked at this discordance between MRI size and pathology size. And you can see that you don't have those significant underestimations. There's still some patients where MRI is underestimating and some patients where MRI is actually overestimating the size. But the question is, if you have better concordance, is that going to lead to better surgical outcomes? And are better surgical outcomes going to lead to fewer recurrences? So there are several retrospective series that are trying to answer the question of what happens if you get a preoperative breast MRI. So one large series from the Cleveland Clinic of 692 patients with ILC showed that for those who had preoperative MRI, 6% overall were found to have a contralateral cancer, half of which were found by that MRI. 20% of the patients had additional multifocal or multicentric disease, but they saw no difference in the rate of positive margins. In contrast, this series of 145 patients from the Netherlands, for those who had breast MRI, they did show that there were fewer mastectomies that were performed in the MRI group and a significantly lower rate of re-excision in the MRI group. A series from Ireland of 218 patients saw that there was no difference in mastectomy rates and no difference in positive margin rates if patients got an MRI versus did not get an MRI. This large series of 603 patients saw that for patients who had a breast MRI, they were more likely to end up getting a mastectomy, and this translated to lower positive margins, so possibly helped with selecting patients for breast-conserving therapy. And then the largest study is this meta-analysis, which included about 4,000 patients. And in the meta-analysis, there was actually no difference in mastectomy rates and no difference in re-excision rates. Some investigators have actually suggested that MRI might confer some harm to patients. So in this study, they defined harm as having to have a benign biopsy because of the MRI and overestimating the tumor size on the MRI, which could lead to more extensive surgery than what that patient may have wanted. And if you define harm in that way, they actually found that MRI was helpful and harmful in the same proportion of patients. Despite these mixed data, however, breast MRI is still recommended in the preoperative evaluation by many organizations, including those listed here. And I think that the fact that we lack prospective data and are relying on retrospective studies might lead to the mixed results that we see in the literature. It's very possible that MRI is used more frequently in patients where the tumor is harder to evaluate with standard imaging tools. And those cases may be the ones where you're more likely to have positive margins and perhaps more likely to end up needing an MRI. So as I mentioned, I do personally use breast MRI, despite the fact that the evidence is actually mixed. And I think that many people recommend it because although it's not a perfect test, we lack a better alternative for delineating the extent of the tumor. So it's still the best test that we have. I think it's important, though, for people to know that the MRI is not necessarily the answer to this problem, and we still need better tools. And this really relates to this overarching challenge of disease assessment in ILC. This truly is an unmet need across the spectrum of ILC. At the point of screening, we lack sensitive tools to be able to detect this, and patients with ILC are diagnosed at later stages. In the early stage setting, we have challenges with surgical planning, and we need better ways to measure responses to neoadjuvant therapy. After treatment is completed in the early stage setting, we really don't know what is the optimal test for surveillance. How frequently should we be performing that test? For how many years should we be performing it? Should we be starting it the first year after, or should we be starting it 5 years after? These are all unanswered questions for patients with ILC. And in the metastatic setting, challenges with determining treatment response really hamper tailoring management and potentially enrollment in clinical trials. When it comes to systemic therapy, we are all very comfortable with the idea that treatments may be tested in the stage 4 setting and then applied to earlier settings. And we may be able to apply some of the lessons that are learned about disease assessment in the metastatic setting to earlier stages as well. In an effort to do that, we're launching a prospective study called the PLUM Registry. This is a prospective study of lobular metastatic breast cancer. To plumb something means to measure it. And the goal of this is really to come up with better ways of measuring disease. This study is open for patients with metastatic lobular breast cancer of any receptor subtype at any line of therapy. When patients are enrolled and undergo a standard of care imaging study, they will also have a detailed clinical assessment as well as ctDNA measurements. This will happen every 3 to 6 months for corresponding with standard of care imaging studies. After an initial pilot phase, novel imaging tools will be incorporated into this registry. I'm happy to announce that we've just received IRB approval at the primary site, UCSF, so should be able to start enrolling patients soon. And for any investigators that would be interested in opening the PLUM Registry, please feel free to reach out to me. And you can see our collaborators and other sites that are planned listed here. So to share with you some of the surgical data from our institution about approaches to improving outcomes, I'd like to share some of our published papers. So we looked at ways of reducing positive margins. So in this study, we had 358 patients with 365 tumors. So some of the patients had bilateral cancers who were attempting breast conservation surgery. We looked at the role of oncoplastic surgery, as well as the use of selective shave margins. So shave margins means that after the lumpectomy is removed from the breast, additional pieces of tissue are removed from the lumpectomy cavity. We found that for patients who had lumpectomy alone, the positive margin rate was quite high, 46%. For those who had a level 1 oncoplastic operation, the positive margin rate was 31%. And those with level 2 oncoplastic surgery, which could be something like a breast reduction or oncoplastic reduction mammoplasty, the positive margin rate was 37%. I do want to mention that at our institution, we're pretty liberal about offering breast conservation therapy for patients who desire it, even if they have a tumor that is multicentric or larger than 4 centimeters. So these positive margin rates are high, and as long as patients are informed of the risks, we are willing to try and achieve that if that's the goal. The overall positive margin rate in the study was 43%. 27% of patients underwent a single re-excision, with the remaining choosing to undergo mastectomy. 1.8% of patients had 2 re-excisions. And overall, of the patients who tried breast conservation, 75% ended up with successful breast conservation. In a multivariate model, we did find that one of the largest predictors of having positive margins was larger tumor size, as well as multifocality. But shave margins and oncoplastic surgery, when you combine level 1 and level 2 together, were both significantly associated with reduced positive margin rate, so a 60% reduction. And similar results have been shown in trials of shave margins for breast cancer in general. And in terms of ILC specifically, there was a large retrospective series from the Kaiser system that showed that oncoplastic surgery was associated with reduced positive margins. So our findings are consistent with the literature. If a patient does have a positive margin, what is the chance of success of re-excision? So the question always comes up, should you try a re-excision, go back to the operating room and remove a little bit more tissue, or should you just go straight to mastectomy? So we had 314 patients who had lumpectomy, and of those in this analysis, 118 had positive margins. For those who had a re-excision, 74% were successful, meaning they did eventually have negative margins. We looked at the factors that were associated with successful re-excision, and we found that older age was associated with successful re-excision, and having more positive nodes was associated with unsuccessful re-excision. The factors listed here were not associated with success or failure of an attempt at re-excision. We also wanted to look at outcomes of breast conservation for patients with larger tumors. As I mentioned, we do have some patients with large tumors who highly desire breast conservation. And the trials that tested the safety of breast conservation versus mastectomy did tend to exclude patients with tumors that were bigger than either 4 or 5 centimeters in size. For patients with IDC, there have been some analyses showing that it's safe to do breast conservation for tumors this large, but there's really very little data in ILC specifically. And this is relevant for patients with ILC because these are the patients that present with larger tumors. So we had 180 patients who had ILCs larger than 4 centimeters in size. 30 of them underwent breast conserving surgery. This Kaplan-Meier plot is showing recurrence-free survival in the patients who underwent breast conserving therapy, mastectomy, or mastectomy with radiation. The good news is that we found no difference in recurrence-free survival. The bad news is that the positive margin rate was very, very high. So again, this comes down to shared decision-making between the surgeon and the patient in terms of how much they want to undergo breast conservation therapy and if they're willing to take this very high risk of a positive margin and potentially having to undergo more than one operation. We also did a multivariate analysis to look at what factors were associated with positive margins. To look at what factors were associated with recurrence or time to recurrence. And we found that the type of surgery was not associated with time to recurrence, but the factors that we would expect were, so larger size of tumor, more positive nodes. And for the small number of patients with HER2 positive or triple negative ILC, that was associated with increased risk of recurrence as well. An interesting finding from this analysis was actually that for patients with these larger ILCs, even mastectomy was not perfect at achieving clear margins. 13% of the patients who had mastectomy had persistently positive margins. So this led us to look a little bit more closely at positive margin rates after mastectomy, specifically looking at different types of mastectomy as well. So in 357 patients with ILC who had mastectomy, we did see that there was a significant association between tumor size and positive margins. This number actually surprised me. I would not have guessed that for a patient with a T3 ILC that the positive margin rate would be this high. So that's definitely higher than I think we would expect, and certainly leaves room for improvement in our surgical management. The location of the positive margin in these cases, in about a quarter of them, was anterior, so on the skin side. We tried to figure out if a patient has a positive margin after a mastectomy, what's the best way of managing that? Should that patient undergo a re-excision? Should they undergo radiation? We didn't have enough patients to be able to parse that out. So we looked at patients who had some form of margin treatment. So those are the patients in the red line here. So these patients who had a positive margin after mastectomy had either a re-excision or radiation or both. And in the blue line are the patients who had a positive margin after mastectomy that had no additional local therapy. And we see a significant difference between these two lines. So I think this suggests that a positive margin after mastectomy is not going to be handled effectively in most cases by systemic therapy alone, and that additional local therapy is indicated. We also looked at the type of mastectomy. So nipple skin sparing mastectomy, where all of the skin, including the skin of the nipple and areola, are preserved. Skin sparing mastectomy, where the skin above and below the nipple is preserved. And simple mastectomy, where typically the central skin of the breast and the nipple areolar skin are all removed. And you can see here the positive margin rates in these series. There are some differences between these groups, but this was not statistically significant. And importantly, we looked at recurrence-free survival in these different types of mastectomies, and we saw no difference in recurrence-free survival, of course, with the caveat that these are not huge numbers. So in summary, patients with ILC do indeed face worse surgical outcomes than those with IDC, with higher rates of positive margins and a need for more extensive operations. We know that imaging tools have lower sensitivity for ILC, and this can have an impact across the entire spectrum of ILC and certainly can hinder surgical planning. Breast conservation is safe for patients with larger ILCs, but positive margins are very, very common, and that's something that's important for patients to know about as they're deciding what operation to choose. However, mastectomy is not necessarily the solution for everyone. There's still a significant number of patients who have these very large tumors where they're still going to have a positive margin after a mastectomy. And this really does underscore the need for better imaging and better systemic therapy so that we can shrink these tumors before we're going to the operating room. So in conclusion, for patients who are undergoing lumpectomy for ILC, I think it's prudent to always take shave margins and offer oncoplastic surgery. If a positive margin occurs, the success rate of re-excision is 74%, which again can help patients pick the optimal treatment plan for them. Lumpectomy can be offered for these large tumors, but the positive margin risk is even higher than usual. For mastectomy, the available data suggests that nipple skin sparing mastectomy is safe for patients with ILC, but if someone has a T3 tumor, there's a very high positive margin rate, and those positive margins do need to be addressed with additional local therapy. Preoperative MRI is a useful but imperfect test, so even better imaging tools are needed. And I would argue, and some may say this is controversial, that there is a potential role for neoadjuvant therapy, even if you're not going to be able to downstage the patient from needing mastectomy and being able to convert to lumpectomy. It may actually improve the outcomes for mastectomy as well. Thank you very much.
Hello. Thank you so much for that wonderful talk. And these are the things that we face every day as we see our patients. Any questions? And I'm not sure about the time because yeah, 1 or 2 questions are fine. So, okay.
Yes. Hello. Good morning. Thank you for your presentation. I have a question. Multifocal or multicentric breast cancer used to be a strict indication for mastectomy. Now we sometimes consider a double lumpectomy, but would you also consider it in an ILC patient?
Yes, I think, is this on? Okay, I think that's a great question. And just to define that, so multifocal means that there's more than one tumor in the same quadrant of the breast, so the same kind of quarter of the breast. And multicentric means that there's more than one tumor and it's in more than one quadrant of the breast. So there was a prospective randomized trial looking at the safety of breast conservation surgery for multifocal and multicentric tumors that was recently published. It was not strictly for patients with ILC, and it showed that doing more than one lumpectomy actually was safe. I think that the problem becomes sometimes just like a technical challenge where if the tumor is spanning such a large area that you just physically can't remove that amount of tissue without significantly distorting the remaining breast, then it may be contraindicated. Sometimes you just are not going to be able to get clear margins. So I would say that if you can get clear margins, I don't think that it's a contraindication. Thank you.
How does the size of the breast influence your decision?
Yeah, that's a very important point. So many of the original studies looking at breast conservation versus lumpectomy used the size of the tumor, but really it's the proportion. It's the relative size of the tumor to the size of the breast. So we will do very large oncoplastic operations for ILC tumors that are 7-8 centimeters in size if a person has a lot of breast tissue and are willing to end up being significantly smaller. So I will involve a plastic surgeon to do a breast reduction. And I think you really have to take that into account. People have talked about, like, is there a specific proportion, like if the tumor is a third of the breast or a quarter of the breast? What I find is that if you're doing a quadrantectomy or maybe a little bit more than a quadrantectomy, that we've had good success rates in terms of clearing the margin. When you're talking about, removing, say, 2 quadrants of the breast, and I don't know if there's surgeons here who want to also comment on this. It is possible, but I think that it becomes harder and harder to get clear margins.
Yes, thank you for your talk. I have a question. We are not familiar to examine margins on mastectomies. So do the pathologists have a specific procedure to do this? Because it's not so usual if the... I don't know. Do you
That's
have
interesting. I didn't know that. And so I know our pathologists do tell us about the margins. I'm not sure if they're sampling them in a different way. Mm-hmm. I can ask Uni and follow up with you.
Okay. Thank you.
Well, thanks, Rita, for that great talk. We saw your data and the data in the literature saying that MRI doesn't always, it's not clear, right, how much it helps. But has anyone broken that down by mass-like ILC versus NME or non-mass-like enhancement? Because we know that sometimes ILC does form a mass, and then other times it's sort of hiding behind all of this non-mass-like enhancement. And one could guess that it would be more helpful in the latter situation, but is that really not broken down well?
I think that you're right. And we have some unpublished data looking at that question. And for patients where the ILC forms a mass, the size on MRI pretty much matches up with the size on pathology. But when it's NME or non-mass enhancement, there can be huge discrepancies with pathology.
So one question I had.
I think Priya would be around. So if you want to ask any questions, we'll do it then. I'm sorry, because we have to move on. So here you are already. That's great. So sorry. So we have, again, a great privilege again to have Dr. McAuliffe. I hope I'm saying your last name right. And I think this is also another extremely important question. And those who treat ILC, we see this all the time. Surgical management of the axilla and lobular cancer can be, I'm sure part of the question would be, can we forego the axillary lymph node dissection? So waiting to hear from you. Thank you so much.
It's a real honor to be here today to present. And I really wanted to thank Steffi for her vision in putting this together, and also all the hard work that went into arranging this, but also the science and the personal stories that have been presented. Next slide. So you can see my outline here that I'm going to follow today. There's a few things I did want to mention. The first is that this is a very complicated topic on the surgical management of the axilla. And so I'm going to try to base my talk on guidelines, but there are exceptions to everything that I'm saying today. And also, I know that there are people in this audience who have worked on this topic and have likely published some work on this topic. And if I didn't include your work, it's only for the lack of time, because this has been a work in progress for over half a century. Next. So why is surgery to the axilla important? The main purpose of operating on the underarm lymph nodes is because it helps us to determine the stage of the breast cancer, which then in turn helps to predict the prognosis and helps us to determine breast cancer outcomes. And then in turn, that helps us to determine the extent of multiple additional therapies, whether that be oncologic surgery, reconstructive surgery, radiation, or systemic therapy. Next. So Rita already spoke about the why axillary nodal surgery can be a problem. And the reason is because it comes together with morbidity, paresthesias, pain, and numbness, and most importantly, lymphedema. Next. And one of the sobering facts about operations on the underarm is we don't think it has a significant impact on relapse-free or overall survival. And we know that back all the way to studies started in the 1970s, including the NSABP B04 study. Next. So why are we even asking about lobular cancer? I think at this point in this conference, I don't even have to mention this, but we know that lobular cancer has different biology and clinical characteristics. But one thing I think is worth mentioning is that we do know that for patients with lobular cancer, that diagnosis independently predicts micrometastatic axillary disease. And so we really want to understand whether the clinical work that we do for breast cancer in general applies specifically to lobular cancer. Next. So let's first start talking about the clinically node-negative axilla with lobular cancer. So that means when I examine my patient, I don't feel any abnormal lymph nodes. Next. So in that case, in order to determine the stage, the procedure that's done is the sentinel lymph node biopsy, where dye is injected into the breast, which then travels to the first underarm lymph node, whose name is the sentinel. And it's identifying an anatomic landmark of the breast. And so sometimes more than one lymph node is identified. If the pathologic results of that sentinel lymph node biopsy shows no cancer, then no additional surgery is done. But if there is cancer in that underarm lymph node, when the lymph node is looked at by the pathologist, then that's where it becomes a little more complicated. If there's multiple lymph nodes that have a ton of cancer in them, next slide, then the procedure is axillary lymph node dissection, which means to remove all the lymph nodes in a certain anatomic framework. And but what do we do when there's just a low volume of disease within the underarm lymph nodes? Maybe one or two lymph nodes involved. Next. So there's 3 randomized clinical trials that help us to understand what what we should do in that case. And I'm going to go through these. Next slide. So the first one is a study called ACOSOG Z11. So this study took patients with small volume disease, either T1 or T2, and had a clinically node negative axilla. So on exam, the clinician couldn't feel anything. Then the patient underwent a sentinel lymph node biopsy, and then there was cancer in the sentinel lymph node. So if 1 or 2 lymph nodes had cancer in it, then they could be randomized in this study to either completion axillary lymph node dissection or no additional surgery. And so what I'm showing you here is the Kaplan-Meier curves, which are showing that from the perspective of survival after long-term outcome, there was no difference if the patient had a completion axillary lymph node dissection or not, and also disease-free survival. Next. So here I'm showing the patient characteristics of this tumor. Next. And so what I want you to focus on here is the number of patients that had lobular cancer. And so we have spoken through this conference that about 50% of patients have lobular cancer. This study actually not only looked at lobular, but also identified mixed ductal and lobular. Next. And so, that tells us that patients with lobular cancer were represented in this study. And as we've discussed here at this conference, we know that there's different phenotypes for lobular cancer, but the majority are positive. So I did want to show you that when this study specifically looked at ER and PR positive breast cancers, the lack of difference in survival and outcome continued to be the case. Next. And as a surgeon, I can't help but put on this slide, which shows that at the spot where there was a positive lymph node removed, in those patients that didn't have the rest of the lymph nodes removed, there was no difference in a local regional recurrence in the underarm. Next. So the next slide was the International Breast Cancer Study Group 2301. And so this clinical trial took patients who had the same low stage disease, but compared to Z11, where all the patients had lumpectomy and radiation, in this study, the patients could have a lumpectomy or a mastectomy. And the other difference with this study is that the patients were only allowed to have micrometastatic disease in the underarm lymph nodes. But what you can see in this graph, which I realize is a little bit small, but you can clearly see that the Kaplan-Meier curves are overlapping when related to disease-free survival, distant disease-free survival, and overall survival. Next. So again, and then another important thing, which would be expected, is that the patients that did not have an axillary lymph node dissection had lower rates of lymphedema and neuropathy compared to the patients that did have a completion axillary lymph node dissection. Next. So this is a forest plot, which looks at a whole bunch of different characteristics that these investigators looked at to determine whether toward the left of the screen favors no axillary dissection, toward the right of the screen favors axillary dissection, and the vertical line in the center, the solid line, is where those groups separate. Next. And so they separated out lobular and ductal. Again, the first thing we can see is that lobular cancer was represented in this study. And so the dotted line next to the vertical line is where non-inferiority lives. And so you can see with lobular that there was no difference between completion axillary lymph node dissection and not in this group. Next. So the last study I want to talk about is Amoros. So it was the same patient population, but in this case, the patients were randomized to either have axillary lymph node dissection or axillary radiation. And so what we're seeing is, again, no difference in overall survival or in disease-free survival. And then on the right side of the chart, what you can is the chart which shows that the patients that had axillary radiation had lower levels of lymphedema than the patients that had a completion axillary lymph node dissection. Next slide. So here we can see, again, the demographic characteristics. Next. And just blowing up the ductal versus lobular, again, we can see that the population in this study also represented the population of breast cancer in general, but that lobular was represented. Next. So it's good to look at these randomized clinical trials because they guide our care, but has anybody looked specifically just focusing on lobular cancer? And our own Rita Mukhtar did this study looking at this population of patients, smaller stage disease with a positive sentinel lymph node. Next. And I really wanted to point out the strengths of this study, one of which is a very large patient sample size. You can see 520 patients circled at the top of the slide. But also something I thought was really critically important was that her group separated out the different phenotypes of lobular cancer. Next. And so thankfully, again, what you can see here is no difference in patients that had sentinel lymph node biopsy versus axillary lymph node dissection. But going back to the square on the right, you can see that even was the case for the different phenotypes of lobular cancer. So this is a really powerful study that helps us be sure about the treatment of low volume disease in a clinically negative axilla. Next. Another study was done looking at epidemiological SEER data. Next. which again shows the same thing in a slightly larger sample size. Next. And so now we're going to turn our attention from patients who were examined and no abnormal lymph node could be felt to patients who a lymph node can be felt. Next. So I would say that a lot of groups have pushed the Z11 data with upfront surgery, which means patients with perhaps imaging that shows only one lymph node involved, that we might target that abnormal lymph node and then do a sentinel lymph node biopsy. But what is considered to be standard is in upfront surgery with a clinically palpable lymph node or nodes to complete an axillary lymph node dissection. So the question is, can neoadjuvant systemic therapy help us here? We know that neoadjuvant systemic therapy can decrease overall within breast cancer the need for removing all the lymph nodes, and also helps us to understand tumor chemosensitivity. Next. So let's first look at neoadjuvant chemotherapy. So we know in this circumstance, tumor biology is the principal determinant of response. Next. But in lobular cancer, next, the rates of pathologic complete response are low. And this is Terry King's work, where she compiled multiple different studies that looked at chemotherapy and specifically focusing on lobular cancer. And you can see that the pathologic complete response rate is low. Next. And so what several groups have indicated is when lobular cancer has a lower ER positivity and poor differentiation, that those patients might benefit more from neoadjuvant chemotherapy. Next. So in the small population of patients that do have an excellent response from neoadjuvant chemotherapy, such that when they are done with that treatment, they have now become clinically node negative, then there are studies that help us to understand, including this clinical trial, 1071, which tells us that if 3 negative lymph nodes are removed, that we think axillary lymph node dissection can be avoided. Next. So more and more information is coming up related to neoadjuvant endocrine therapy. Previously, we were talking about neoadjuvant chemotherapy. And currently, the data is still scarce to help us to understand how the management of the axilla will be changed based on the rates of the fact that the patients that actually get a pathologic complete response are low. Next. So where do we go from here? Next. Can axillary surgery be omitted in any population? Next. And we think that it is the case in selected cases. And I'm going to go through 2 scenarios to kind of talk about this circumstance. Next. So the Choosing Wisely guidelines were an initiative that were originally put out by the American Board of Internal Medicine. In 2016, our Society of Surgical Oncology put out a recommendation: do not routinely use sentinel lymph node biopsy in clinically node negative women over the age of 70 with early stage hormone receptor positive, HER2 negative invasive breast cancer. And essentially the thinking was that, remembering that the main purpose of checking the lymph nodes is to help us to understand stage, which then helps us determine prognosis and then additional treatment. If no changes are going to be made based on the results of the test, maybe we don't need to do it. So next, our group and others looked at whether Choosing Wisely was an option that was specifically could be used for lobular cancer, partially because, as I mentioned before, the way that lymph node spread occurs in lobular cancer could be different. But in our group of 250 patients, we did find that there was no difference in patients that underwent a sentinel lymph node biopsy versus those who did not. Next. And this result that we reported has been published in much larger series. Next. For example, in the National Cancer Database, over 12,000 patients with smaller tumors were looked at. Remember, these patients are over the age of 70. And so they also showed no increased risk of nodal positivity. They did make a point of mentioning that most of the patients were still undergoing sentinel lymph node biopsy, even though they were a patient that met Choosing Wisely guidelines. And it is true that the population that they looked at was passed from before these guidelines came to date, but it just shows that there is opportunity to do better in right-sizing the surgical management of these patients. Next. And finally, I want to finish with a study which actually was just published last week, and surgeons are really excited about this study from a group in Italy. Patients were, it's called the SOUND trial. Patients participated in this study, not only in Italy, but Spain, Switzerland, and Chile. This study enrolled women of any age, not just older women. They could have tumors that were up to 2 centimeters, which is T1, the earliest stage. In this case, it wasn't just a clinical exam, but also a negative preoperative axillary lymph node, a preoperative ultrasound, excuse me. And then all the patients had to have a lumpectomy and radiation. And they write in their report that as this study was being written, it was at the time of Z11, where that was the inclusion criteria for that study. And the primary endpoint was a distant disease-free survival. So they just published last week their follow-up of just over 5 years. Most of the patients, but not all, were ER positive. Next. And so what they found was that there was no difference in distant disease-free survival. To me, this graph is slightly hard to look at because it's a graph within a graph. So what you can see is the very top is the actual Kaplan-Meier curve, but then in the center of that graph, it shows you just a small portion of the graph, so you can see the line separate, but it's just another depiction of the distant disease-free survival, but there was no difference there. Next. Nor in disease-free survival. Next. Nor in overall survival. So surgeons are really excited about this study, that maybe there would be less that we need to do in the axilla in patients with very low stage disease. Next. And one of the things I thought was interesting was that in the no axillary surgery arm, within the 5 years of follow-up, there was a very, very low axillary lymph node recurrence in that in the underarm spot at 0.4 centimeters. Despite in the group that was randomized to receiving the sentinel lymph node biopsy, the number of lymph nodes found there was 13.7%. And since the groups were randomized with equivalent outcome, we know that patients had disease that were in the axilla that wasn't removed. So where did that disease go? Well, what it shows us is that the other treatments that are used for these patients, radiation and systemic therapy, are very effective. And so what we know is the surgical removal isn't necessary in every single case. Next. And again, we're looking at the demographics here. And next, I'm going to show you that lobular cancer was included in the cohort of patients in this study. So that's very exciting data from the perspective of the surgeons. Next. So in conclusion, with low volume of involvement of lobular breast cancer in the axilla, we don't do a sentinel lymph node biopsy. We do a sentinel lymph node biopsy currently, but it's a moving target, but axillary lymph node dissection is not warranted. However, in patients who have a clinically node negative disease, in most cases, axillary lymph node dissection is done. But with appropriate selected patients who are receiving neoadjuvant systemic therapy, axillary downstaging could be possible, and so that we can reduce the utilization of axillary lymph node dissection and the morbidity associated with it. So essentially, the take-home point here is that we really want to do the right axillary management for the right clinical scenario, and that lobular breast cancer follows the axillary management of the other breast cancers. Next. In my last minute, I'm just going to talk about a clinical trial which isn't related to axillary management, but several of the advocates and other investigators have asked me about this study, which started here, but is open nationally, which is the TBCRC ILC study. It takes patients who are postmenopausal, who have ER-positive lobular cancer, and they're treated with a very short course of one of the standard endocrine therapies. And this is a window trial, so we're looking at the tissue from the initial core biopsy and comparing it to tissue at the time of surgery. Next. And the study is looking at change in the proliferation index, which is called Ki-67, from baseline to post-treatment. And there are multiple secondary endpoints, and tissue from all these patients is being collected so that we can run many interesting studies. So for those that approach me individually, what I said to them was the study is not done. Next. But it's really important that to thank all the people that have been very involved with this study. Rachel Jankowicz, who you'll hear from later, initially wrote this study, and it has been funded by many groups, and we are just grateful for all of the women who have participated in this study, and happy to take any questions.
Great, fantastic talk. Thank you so much for that. I'm sure this is an area of controversy, so there will be a lot of questions. So does somebody have any? Okay, all right.
Oh,
Well,
yes, I have a question. So post removal of those nodes, can you talk about the surgeries that I hear can be potentially successful to reconnect remaining lymph nodes to veins in the arm? And do you find is that successful? I heard there's not very many surgeons doing that.
So there are several different studies or several different procedures that can reconnect some of the lymphatic drainage to reduce the likelihood of lymphedema. And you're right, the studies are not so clear, and it's not being done by everybody, but it's something that we're hopeful can, reduce the morbidity of lymphedema. But if we never had to do the surgery in the first place, because it's not changing the patient's management, that might be another way that we could reduce the likelihood of lymphedema.
Yeah, and it's probably not covered by insurance, correct?
Yes,
The
it is.
surgery, it is.
No.
I was the first patient at MD Anderson to receive lymph venous bypass prophylactically during my mastectomy. I give my.
That's correct. Fantastic. Thank you. We do it at OSU as well. So yeah, and most of it is covered by. Yeah, please.
Axillary reverse lymphatic mapping. So in surgery, if your surgeon can inject blue dye in the inner arm of the side that they're doing the axillary surgery, that will highlight the lymphatics from the arm that course through the axilla while you're doing your axillary surgery, be it for sentinel lymph node or targeted axillary dissection. If the lymph node for the breast happens to share the same lymphatic coming from the arm, therefore you have a blue line going to possibly a blue node that is hot from your sentinel technetium, then you'll have to replant at the time of surgery the blue arm lymphatic into a vein, because you have to take the shared lymph node both from the breast for being hot and being blue from the blue dye in the arm. But to reduce the risk, ask your surgeon, do they do blue dye axillary reverse lymphatic mapping on the side that you're getting the surgery? In the operating room, anything I see that's blue, I tell my fellows and residents, don't touch it, even with the retractors, because that's how you set yourself up for a risk of lymphedema for the patient.
Thank you for that. And okay,
Yeah.
yes.
Sorry, one more quick
There's
question.
one more question. Sorry.
So-
We'll stop at that.
Yeah. On the sound trial that used ultrasound's not really super accurate for identifying nodal mets and lobular cancer specifically. Should we be concerned about that?
I definitely think that how well a study identifies the problem that you're looking for, the more effectively you can make decisions based on the results of that study. But really, the point that I was trying to make, especially since the study was just published last week, so it's right hot off the press. But I do think that there will be a population of patients for whom we won't have to do any axillary staging at all.
So much. Appreciate your great insights. Thank you.
Good morning, everybody. Now we have a really exciting session of treatment resistance and metastasis. And we have a fantastic line of speakers, really a stellar group of speakers. And we're going to be hearing about very different topics, really a colorful session. We will be hearing about liquid biopsies. We'll be hearing about also emerging opportunities on novel biomarkers in specific for lobular carcinoma, and about post-mortem tissue donation programs. So our first speaker is Dr. Christopher Neely from Cornell. He's the Chief of Breast Medical Oncology, Associate Director of the Englander Center of Precision Medicine, and he's truly an expert on the management of hormone receptor positive metastatic carcinoma. And he's going to share with us his insights in liquid biopsies and its potential in deconstructing the molecular and clinical evolution of lobular breast cancer. The floor is yours.
Thank you. Thank you for the introduction. Thank you for the invitation. I think this is a fantastic conference. Everybody agree also because we are interacting with patients. Microphone, okay. So I said, for me, it's always important to have an audience that has patients because we have patients' problems to solve. And I think liquid biopsy, I will try to convince you, is that set of technology is going to help to understand a disease for which it seems like we don't have an appropriate imaging. We don't have a way to monitor. We don't have a way to address an initial disease. So we're going to bring you to the liquid biopsy evolution and also with the different technology that we use. So these are my disclosures. Let's just to try to summarize what we know about the different liquid biopsy technology and the use that we do in the clinic. Many years ago, there was a CTC detection enumeration that showed that more than 5 CTC are metastatic breast cancer are prognostic. And over the years, this has been proved over and over again at the point that we can actually stratify patients with metastatic disease in 2 different groups, rapid progression versus lower progression of low disease based on the CTC. We can also do molecular analysis, and the cells are really possibly being tested for HER2 and, of course, for ER. There are other components of the analysis of CTC. You can see CTC clustered. You can see some extra vesicles, and this can provide additional prognostic and molecular information. Those 2 are more research, though. But you can start thinking about the fact that, in fact, in the blood, beside the DNA, you can actually look at different components, cellular. We can talk about this cellular tumor residual disease later. You can go into single cell analysis and really monitor clonal evolution. Most of the field of liquid biopsy has been focused on cell-free DNA. And this is now standard of care clinical testing, believe it or not. In the last 5 years, many studies show that you can actually study the disease, find actionable mutations, monitor the evolution just with a blood test. It measures also tumor burden in MRD in primary setting. And again, we will review some of this data. So let's start with a case, because I think a case will tell you even more how we can implement this in the clinic. So this is a patient that I had at Northwestern, presented with metastatic disease. She has a history of lobular cancer. You heard many times that this lobular cancer sometimes presents as a large tumor that cannot be seen in imaging. So this woman went to surgery, opted for mastectomy and axillary dissection. She had a 10.5 centimeter tumor, strongly ERPR positive, HER2 negative, and 7/18 positive lymph node. She received adjuvant chemotherapy, radiation, went on tamoxifen, then an anastrozole, a reasonable number of years on endocrine therapy. Then suddenly she started to complain of dyspnea and pleural fluid. So This was a procedure was done and found that she had, in fact, a recurrence from the same tumor. And from the same tumor that was ER/PR positive, now PR is a little bit less, was HER2 negative. What do we do right now? Well, obviously, the standard of care would have been to start Faslodex and CDK4/6. She had a tissue NGS. It took 3 weeks to get a tissue NGS from Tempus. They show an HER2 mutation and an ESR mutation. So suddenly you start to have an actionable mutation that you cannot have identified with standard test. So if this was the standard of care, and now we have this information, what do we do? Obviously, we need to act on this because she has a better chance if you were to do an HER2 targeted therapy. At the same time, she had Guardian 360, she had a CTC. The CTC revealed that she had 12 CTCs, of which 9 were HER2 positive. And the Guardian 360 identified the same variant of HER2 mutation with a allele frequency of 9.5 and an ESR mutation with a 3.5. So she started treatment with neratinib fulvestrant off protocol because she had no measurable disease. And she was able to get a complete metabolic response, wonder what the FastPET will have shown, right? And then went to really continue for several months after that. So this is the Guardian 360. You can see that in March, we already had an indication that she was responding. Clearly, she was now reaccumulating fluid. The allele frequency was significantly down for the HER2 mutation variant as well for the ESR. And she continued to do well for quite some time. So cell-free DNA, what do we learn from here? First of all, the standard of care sometimes for lobular cancer may not be the standard of care because you need to know the molecular drivers of this disease that could be different. And we heard yesterday some of the presentation. Second, the liquid biopsy can identify through CTCs, and in this case, to cell-free DNA, which the drivers are, and can also help us to monitor the disease and maybe predict even before the imaging, irrespective of what the images is, what this patient was going to do. So I think this case, one of many, that simplified the role of liquid biopsy in lobular cancer. Let's take a step back and let's look at the CTC in lobular cancer. First of all, I want to remind you about the many studies that have been done in the primary disease where CTC were measured, particular studies done in Europe, during the neoadjuvant phase, the residual disease, the residual CTCs. This French study look at the recurrence higher in patients with more than one CTC. Many German studies looking at the CTC after adjuvant, during adjuvant. So during this period of time in the adjuvant setting, you can imagine that we can potentially use the CTC as a way to identify this cellular tumor residual disease. So yesterday there was some discussion about what do we do if we have completed treatment and we don't have any way to monitor. We don't want to do imaging unless we are at risk. So who is a high risk? Well, we know that having CTCs in this setting is a high risk. So when you look at the metastatic disease, there were studies comparing the lobular cancer versus the ductal cancer. And this circulating tumor cells number in patients with lobular cancer is always higher. Which here you can look at the more than one cells. There is a large proportion, 84% of the patients, also more than 5%. And some patients have more than 80 CTCs. This is a small tube of blood, 7.5 cc. So it's a significant number of cells. This is due probably the loss of Ig in these cells really shedding and circulating. So it's almost a liquid tumor that we'll be able to monitor with these blood tests. And this is the distribution based on the number, the cutoff number. You see the median is much higher, almost 70 cells for CTC. It doesn't mean that this patient will not respond to endocrine therapy. Where patients start very high, respond to endocrine therapy, there is a drop of the CTCs. But this is a very accurate measurement of the disease in a large proportion of patients. It is better than standard tumor markers. So look at the cutoff again of the 5. And this was the Kaplan-Meier curves where you see that probably, if you want to look at prognostic implication, maybe in this lobular cancer group, 20 would be a better prognostic cutoff. So this is the different cutoff, though. You see the smaller CTC number, less than 5. There are very few patients. But in general, the higher the number, the higher is the risk of recurrence and progression. And if you don't see a drop in the follow-up of these patients, obviously it's a problem. So what do we do with that? As I was mentioning before, there is a possibility to look at biomarker. So this is the cell search system, the only FDA clear. You see the 3 channels actually looking at the cells that have cytokeratin after EpCAM enrichment and CD45 negative. These are your epithelial CTCs. The fourth channel is for the additional biomarker. So HER2 comes natural because it's an actionable biomarker. So of course you can look at 1, 2, 3 plus. Many times this HER2 was reported in the past as positive, whatever positivity means. So our group and others in Europe have been trying to better characterize particularly the 2 to 3 plus versus 0 or negative 1. And you can do this with different spiking experiment cells and then go back and really identify the cells in your reading when you test this patient for CTC enumeration. So you get to the point where you see a number of CTC 2 to 3 plus. This is also true for patients that have HER2 negative in the tissue. So there is an evolution and a change in the HER2 expression. This can be very important. Why is it important for lobular cancer? Because in lobular cancer, there is a higher percentage of cells with HER2 positive. So you have a larger number of CTC and a higher percentage of patients that have CTC with HER2 positive disease. This may represent an opportunity and evolution for this patient. You see in this case, percentage of HER2 positive CTC more than 20%, and the lobular cancer being almost 40%. So there are other technologies that allow you not only to enumerate the cells, but you can also collect the cells and eventually grow organoids. We were talking about this yesterday morning. So there is a possibility, a couple of technology. One is the Parsortix system, does not damage the cells, and you can actually identify these cells by EpCAM, and of course the typical biomarker and DAPI for the nucleus, and then these cells may be put in a culture system, and we are trying to develop organoids using a particular patient with lobular cancer because they have the largest number of CTC and the largest number of clusters. And I want to talk briefly about the clusters. So when you have patient with number of CTC, these cells may not only be single cells, but can also organize as clusters. So the one question that we ask, if we were to combine now CTC and the cell-free DNA, will you see any correlation, any particular molecular driver in the cell-free DNA will be associated with high number of CTC or clusters? And we do that, and we see that HER2 positive CTC are, for example, associated with HER2 mutations, and of course, with HER2 amplification. But most importantly, with these clusters, the indication of more aggressive disease are also associated with somatic alteration in CDH1. Yesterday was all about CDH1. So the patients with mutations in the CDH1 are in lobular cancer. The lobular cancer, high number of CTC, high number of clusters. And I think we have done something together for that purpose. So CTC cluster are important for metastatic progression. And I think we need to really focus our research in this particular area in lobular cancer in order to see what type of possibility we have to block the metastatic spread and metastatic progression. So, but let's go back to the cell-free DNA, because many of you have heard about cell-free DNA, and I suppose some of you patients had a cell-free DNA testing at some point. I hope that was used for your care, because these are very important in understanding the driver mutation of the disease, as well as also the progression and the evolution of the disease. So we put together a consortium of academic institutions that use Guardant test and cell-free DNA testing and try to extract real-world data, essentially looking at creating a red cap with the clinical annotation, the variants, and the evolution of the disease. And so we can ask different questions. One question was, what's the molecular feature of cell-free DNA in lobular cancer? First, we look at the prognosis of this patient. They're pretty much in the same overall survival group. These are all metastatic patients. And then we look at the landscape of this CDH mutation, CDH1 mutation, and CDH1 co-mutations. What is associated with the CDH1 mutation that identify lobular cancer? And we have more than 900 patients. And you see the most common are many that were mentioned yesterday. PI3K, obviously, LB2, approximately 10%, FGFR2, ESR, of course, NF1. So these are not uncommon mutation, but LB2 is higher, as was already mentioned yesterday, compared to ductal cancer, for example. This is an opportunity. This is the patient that I just mentioned to you. So I went back to the database from Guardant, and also this was 7,000 patients, essentially show essentially the same type of mutations when you look at the specific of the lobular cancer on the top and a difference with the other, the IDC and the mixed histology. So we know exactly how the cell-free DNA can identify this mutation upfront in patients that are candidate for actionable mutation therapy. So PI3K mutation, ESR mutation are already in the guidelines. And what is coming? AKT, and of course, P10. Hopefully, we're going to have another drug, capivasertib, to treat patients that have this particular pathway alterations. And yesterday, we heard about this is very important, probably lobular cancer more than ductal cancer. So we have other drugs that are affecting the ESR1 mutation, and hopefully we're going to have at least 2 or 3 approved. The tricky part will be to identify, to match which is the best drug for a specific variant of ESR mutation. And I think this would be an interesting consideration for the future because these companies are all competing with each other. So this is the lasofoxifene, that is a SERM that has been tested in the ELAINE-1 first and now in the ELAINE-2 in combinations compared to Faslodex. So patients respond better to this drug compared to Faslodex when they progress to first line, and particularly if they have an ESR mutation. So you see this particular study was designed in a way that they could monitor the different variants and the change in the different variants compared to the 2 drugs. And it clearly appeared that similar to what we are seeing in less details with elacestrant, this drug is more effective in some of the most common mutations, particularly in the Y537S, that is a mutation for which there is resistance for fulvestrant. And then capivasertib hopefully will be approved in the next couple of months. This is the Capitello 291 study that was presented at San Antonio and published in the New England Journal, where patients were progressing on a first-line primary CDK4/6, randomized between the drug with fulvestrant versus placebo fulvestrant. And there were 2 endpoints. One is the progression-free survival for overall population. The other one for the patient that had an AKT pathway altered tumors. And this was approximately 45%. You see, there was a benefit for both, of course, primarily in the altered population. So it will be interesting to see if the drug is approved as a second line or is approved only in a mutated patient. Irrespective, I think you would like to know if they have a mutation using a liquid biopsy maybe. You would like to monitor the change during therapy to see if there is a prediction of response during treatment. So this is to summarize how we can use liquid biopsy essentially over the course of the disease. We have CTCs, diagnosis, and later in the cell-free DNA, we can have MRD, and we can have MRD looking at cell-free DNA or CTC at that point. You can detect the molecular recurrence, and the molecular recurrence obviously is important because if we're able to treat before we have the symptomatic recurrence, maybe we can even be more impactful. The other question, of course, is in the MRD, there are tumor-informed and not tumor-informed, and that will be very critical to identify which patients benefit from tumor-informed. I think the more aggressive upfront are the one that triple negative, for example, are the one that they need a tumor-informed and usually progress within the first few years. But for a lobular cancer, the progression is later. Maybe we should think about non-tumor-informed because it will be much more difficult to retrieve tumor patients that are in the follow-up 4 or 5 years. It's going to be a nightmare, if anything. So in conclusion, I think it's clear that ILC is a distinct pathological entity. We all agree that also clinically behave different. Also with the liquid biopsy, you can certainly identify difference with regard to the CTCs, the higher number, clusters, HER2 positivity, very important, and also association with ESR mutations. And I think this makes the understanding of endocrine resistance even easier when you look at CTCs. CTC could potentially be used also in the adjuvant monitor MRD. Who wants to just wait when you have 4 or 5 lymph node surgeries done? The recurrence can be later, but that should do something, not imaging, but just blood test. And with regard to the metastatic and the MRD studies, certainly there is a major role for cell-free DNA. These are tumor that shed and certainly can be identified maybe early, particularly with regard to disease that is peritoneal, is pleural fluid, and is in locations where imaging may not be really appropriate. And then we have the question of, can we screen women for lobular cancer? So we just got a DoD grant for a early detection study using liquid biopsy to compare with mammogram. I think this is the future because not everybody can get an MRI. Mammogram is not accurate. So why don't we try to test pushing the concept of liquid biopsy for early detection so that everybody could have access to screening. And this is my lab. And I hope that we can continue to talk about this in the future. Thank you.
Thank you so much, Dr. Fanilli. That was a fabulous talk. We have a question from the audience. Please. Yes.
Very nice talk. So I was wondering about the clusters. I would have naively thought with the E-cadherin not being around in the lobular carcinomas that maybe they would be floating more one by one in the bloodstream.
Yeah, actually,
tail on, are they glued together by leukocytes or by platelets? What is known?
It's a combination of, we actually had other studies looking at cluster where you look at adhesion molecule like ICAM, for example, and CD44. So there are other factors, except, these are E-cadherin negative. They contribute to the cluster formations. And these are patients usually are in much more advanced stage. And these cells appear to be also covered by platelets. So there is a coagulation component as well. No, at that point, there is no difference.
Yes, just to add a comment, in the LCR, non, comment on dit, the metastasis within the effusions in the peritoneum or in the liquid, the meninges.
CSF.
Yes, thank you. Sorry for missing my words. So we have the same appearance. The cells seem to be in cluster. Yeah.
Yeah.
Hi, Massimo, thanks. Great talk. I had the same question actually, and I wondered whether it was a peak adherence switching that we've heard about before in lobulars or some other factors where adhesion molecules get switched on. But I'll ask a different question about ctDNA. Do you get less ctDNA in lobulars compared to ductals because they're a bit more indolent? Maybe there's less apoptosis going on?
Well, this is a study comparing the metastatic setting. So they already established patient with bone or visceral or other sites. So there is no less surface DNA. We haven't noticed any difference in the amount of surface DNA. Yeah. And actually the patient that I just showed, they had a significant high allele frequency.
Okay, excellent. Thank you so much. In the interest of time, I think we will go ahead with the next speaker. Thank you, Dr. Smith. Our next speaker is Dr. Peter Simpson from the University of Queensland. Dr. Simpson, he's a scientist with interest and expertise in molecular pathology, and he has a special focus on invasive lobular carcinoma. He's the head of the cancer team and a group leader in cancer genomics. He's also a member of the scientific advisory board of the Lobular Breast Cancer Alliance. And he will be discussing about ILC-specific biomarkers. Whenever you're ready, Pete.
Thank you. Thanks very much. And thank you. Can you hear me at the back? Is the microphone okay? Yeah, great. Thanks, Steffi, Adrian, for the invitation and for putting on a fabulous meeting. My title was a bit vague in the beginning because I wasn't sure. I knew what I wanted to talk about, but I wasn't sure if I had enough data to talk about it. So, but I will talk about LobSig and a few other stories, short stories about some biomarker discovery things that we're starting to get into. But before I do, I think Pittsburgh is becoming my favorite city. I'm now a Pirates fan for life, and I think I must have preempted because this year I've been involved in a fantasy baseball league with some friends. And I don't know if you can see my team up there. I haven't done very well, but the Pittsburgh Poms. So I have this affinity with Pittsburgh now, which is wonderful. I was also born in a steel city in the UK. So anyway, so LobSig is something that we've been on quite a long journey actually with in the last few years. And it kind of gives us waves of excitement and anxiety about whether it will actually be useful or not. And hopefully we'll be able to show you some things that are quite exciting still. So just to give you a bit of a background on LobSIG, I think the important thing about this, so this is a gene signature that we developed perhaps accidentally. We weren't looking to develop a gene signature, but it was quite a good, in the end, prognostic signature for lobular breast cancers. And the important thing was that it was developed with invasive lobular carcinomas from the beginning. And that was in contrast to the other risk of recurrence signatures that were on the market. And there's quite a lot of debate about how useful they are in lobulars. But the LobSIG score has 194 genes, and the expression of those genes was able to stratify lobular breast cancer patients into high and low risk of recurrence. And the important thing about the signature was we were able to stratify patient samples that were classified as grade 2 ILC, which is this sort of the vast majority of lobular carcinomas, but it kind of fits in the middle of do we know whether these are high risk or low risk? And it stratified these patients pretty well. And we did an in silico analysis of other gene signatures on the market to see how it compared, and it was more significant in predicting prognosis compared to these other well-tested, prospectively tested, in some cases, signatures. The other important thing that we found was when we looked in this group of patients which were classified as NPI moderate, which is the Nottingham Prognostic Index, which is another way of prognosticating breast cancer patients. And this was a really striking stratification of patients using this signature. And then if you look at the kind of the genomic components of these tumors, those that had the high risk of recurrence from this LobSIG score had a plethora of different gene mutations, and we've seen quite a few of these already. ERB2, ERB3, NF1, ROS1, AKT. These tumor samples that had these mutations were all in the high risk category. So what have we been doing since then? So we've been embarking on a quest to get funding, first of all, and then to try and validate this LobSIG signature. And this is a bit of a disappointing slide, really. So we developed a nanostring custom assay test and looked in a cohort of patients from our institute. And perhaps the text is a bit small, but you can see some separation in lines based on the classification of tumors with this signature, but it's not very significant at all. We can probably play with this signature a little bit more using that nanostring assay, but I want to talk to you more about the immunohistochemistry that we've been doing, because we feel like for something like this to be more readily implementable in a pathology lab, immunohistochemistry would be a more useful tool. We obviously can't perform immunohistochemistry on 194 genes, so we did a statistical test and identified 14 genes that had the similar power to the 194 at predicting outcome. And I talked about some of this immunohistochemistry back in the virtual symposium some years ago, 2 years ago. In our wisdom, we went back and redid all the immunohistochemistry because the original plan, we involved different students, an honors student here, a graduate student here, a medical student here, and we needed to be a bit more robust. And we had a pathologist that came in to do an MPhil, and she's looked at all of these 14 proteins in a cohort of 273 lobulars with long-term follow-up. And it really breaks my heart that I can't tell you what these proteins are at the moment because our business development manager won't let me, but which is kind of against the spirit of things, but we will hear about them in due course very soon, hopefully. So the immunohistochemistry for these 14 proteins, some of them weren't very good. The antibodies weren't very good. Some of them didn't turn out to be very significant prognostically, but we have 4 proteins that are particularly interesting. Three of them, there's very little known in the literature about what these proteins do. There's some evidence that they bind to nucleic acid, so presumably they need to be nuclear proteins. One of them is quite well characterized as a helicase, which is number 4. But if you've got a keen eye for 1, 2, 3, 1, 2, and 4, you can see that these are all that the brown staining is all in the cytoplasm rather than being in the nucleus. And so maybe the function of these proteins isn't necessarily what's impacting the prognostic capability, but the fact that they're perhaps not able to get into the nucleus to conduct what they're supposed to do. That's just a theory that is pretty unfounded at the moment. But and actually looking at number 4, protein number 4, it's actually got a really complicated staining pattern. Sometimes it's only found in the nucleus. Sometimes it's only found in the cytoplasm. Sometimes it's in the nucleus and the cytoplasm. And sometimes it's in the nucleus and the cytoplasm in some cells, but not all cells. So it's got a really kind of, it's a difficult protein to score for this reason. But if you look at the survival curves in this plot, you can see that actually that's subcellular localization and the intensity of staining for that protein does have some prognostic insight. And it seems like if you have high expression in the cytoplasm, which is the blue and the black curves, is more predictive of a worse outcome. So a particularly complicated protein to score, but it looks interesting. So these are the 4 curves for these individual markers. And again, I'm being a bit vague on what the different curves mean, except for the one I've just showed you. But with different staining patterns, intensity and localization, we can stratify these patients into different groups prognostically. And it was really always our thinking that we would combine these markers into a single prognostic combination of markers. So LobSig4 in combination looks like this. And so those patients in the red group have a particularly poor outcome in that period of the first 10 years post-diagnosis. But if you can drop it down to 4, can you drop it down to 3? Oh, so before I go on to that, so we have studied these 4 proteins in separate tissue microarrays of invasive carcinoma, no special type. And actually the 4 proteins do look interesting in NST, but it's less prognostic. So if you can cut it down to from 194 to 4, can you go down to 3? And so in a sort of a leave one out analysis, we have each of those 4 proteins left out of each of these different plots. And you can see the plot in the top left looks particularly interesting. So leaving one of those proteins, actually the complicated protein that I told you about, gives you a really striking curve as well. So LobSig3 looks particularly interesting. And you can probably see where I'm going to go with the next slide. If we take out another protein, it still looks pretty significant in terms of stratifying patients as high risk if you just have 2 of those 194 genes by immunohistochemistry. And so that's really where we are at the moment. And those analyses are just being completed in the last month or so. We communicated with Emad Raka in Nottingham at the beginning of the year to see if he could help validate externally. This is always part of our anxiety, is that we're just doing it and creating our own things with some internal bias that we have. But so we've been talking with Emad and a PhD student pathologist, Sharuk, who has independently bought the antibodies and has been staining their cohort and independently scoring the tissues with some guidance about what we were finding for our markers and with our optimized conditions. And this is all very preliminary, and hopefully I'll talk with Sharuk when I'm in the UK next week. But the 2 examples there do show that there is some consistency in an independent cohort. But these studies that we've done are all in old cohorts, so 30-year 25 to 30 years of follow-up, and we're really looking for a call out to help us validate in a more contemporary treated cohort and actually our cohort, we don't know anything about the treatment the patients had. So we're looking and asking for some help to help validate this in a contemporary cohort with very defined treatment information. So we still feel that there's potential for this LobSig in whatever guise, whether it's 4, 3, or 2, to be possibly a companion diagnostic for stratifying patients with a high risk. And then maybe those patients with a high risk, you increase surveillance, you increase testing, and you increase the potential for targeted therapy for those patients. But as we were talking about this morning on our table, probably we should do that with everybody, regardless of whether they're high score or low score. So I just want to move on, and please, Frisia, just cut me off when my time is done. But I want to talk about some biomarker discovery things that we've been doing using digital spatial pathology. And we heard a really nice talk on Thursday from Osimo and from Steffi and Adrian's lab about looking at spatial profiling in mixed ductal lobulars. I just want to show you one mixed ductal lobular case that we've been, as part of a small cohort that we've started to look at, because I think it highlights the power of this technology for understanding mechanism of disease. So this is a kind of a region of the tumor that we've particularly targeted for investigating. Perhaps it's not too evident, but these are nests of tumor cells of ductal classification. And then we have tumor cells that are tracking along this fibrous element, which are showing progressive changes as you move away from that ductal element to becoming more lobular-like. So they are, and in fact, if I show the next slide, we have done E-cadherin, beta-catenin, and P120 staining, and it's showing the same morphological change and change in these biomarkers as you progress to a more lobular-like growth pattern. So progressive decrease in beta-catenin and P120, beta-catenin and E-cadherin staining, just within this very small area. So if you do digital spatial profiling, and we use the 10x Visium assay, you can very nicely annotate specific regions of the tissue that you want to extract the RNA sequencing data and then look at the biology of the tumor. So each of those colored dots we've annotated to be these specific regions of ductal-like, an intermediate E-cadherin positive-like, intermediate E-cadherin aberrant-like, and then a lobular-like, which is E-cadherin negative. So you can we make the assumption that there's a trajectory here, and then you can look at differentially expressed genes between those different comparisons. So it's a really nice way of seeing evolution of a tumor within a very small space. And I was very pleased if Jason is here to see that he was interested in SCOOB2. So if you look, I don't know if you can read, but this gene up here, which is differentially expressed between the E-cadherin aberrant and the E-cadherin negative, is the most differentially expressed gene is SCOOB2. I've just associated this with an ER positive type phenotype in the past, but I was just reading the other night that it's involved in pushing cells to be epithelial and encouraging E-cadherin to be present and minimizing beta-catenin activation of the Wnt pathway. So, and here we're seeing, and actually SCOOB2 is strong, the expression is strongest in the ductal component, and it seems like there's a progressive decrease with decreasing E-cadherin. So maybe SCOOB2 is a driver of E-cadherin deficiency in some cases. So the other anecdotal story I want to talk to you about is an extension of a paper that we published again a few years ago, looking at progression of breast cancer to gynecological organs, because we know lobulars have a propensity to metastasize to sites like the ovary and the tubes. And so we collected a cohort across Queensland and studied these tumors with morphology, with immunohistochemistry, and with some genomic profiling. And we saw, so this is just one particular case where we saw, this is the primary tumor, the expression of estrogen receptor. The metastases were all actually more positive than the primary tumor, but sometimes the primary tumor loses it. There's loss of expression with metastasis, exactly what Christine was talking about with a question the other day. So you can see quite clear evidence of progression of these biomarkers with metastasis, and metastases within the same patient have different profiles sometimes. So I think digital spatial profiling gives you a really good opportunity to look at different signaling pathways between different tumors. I don't have much evidence because we haven't really analyzed the data, but I just wanted to give you a quick insight into a couple of, so this is a tissue microarray of 4 cases that we've studied where we have the primary tumor and multiple metastases from the same individual. So this case is particularly interesting because we also have LCIS and invasive lobular carcinoma in the same tissue specimen, and then multiple metastases, a lymph node, and a mental ovary and tubes. And the key thing really I want to highlight is that these specimens are from 1993. So they're archival specimens that are 30 years old. And we're getting really nice gene expression data from this spatial transcriptomics. And probably in the interest of time, I won't go into this differential expression plot, but it's really encouraging that we can look at these really old specimens and get some interesting transcription data, which we probably can then look at estrogen signaling perhaps, and how this is changing in different metastases. I just want to highlight a resource that we've been creating in Brisbane as well, which we call the CircBR, which is circulating biomarkers of relapse in breast cancer, where for patients that have a high risk of recurrence, we're tracking patients with regular blood samples and a quality of life survey. And we've recruited over 600 patients. And I really wanted to highlight that we've recruited 83 patients with lobular carcinomas. We have approaching this 6-year mean follow-up period post-diagnosis. So far for the lobular patients, we have 6 recurrences. And unfortunately, I think now we've hit this 6-year moment, as we've been hearing, that we'll have more recurrences in this cohort. But this will then give us a kind of a nice resource to start exploring biomarkers, as Massimo was talking about just before me. So my summary is just nice and simple. Again, it's a call out if you have resources of lobular carcinoma patients diagnosed within the last 10 years with very good treatment data and clinical follow-up data, we'd be very happy to talk to you about it. And I'd just like to acknowledge Lauren, who's the pathologist who came in and has done an awful lot of work with LobSig4, moving down to LobSig4, LobSig4 3 or 2. And many of you know Amy, who's also done a lot of work in this area. And my final acknowledgement is to the patients who have consented to be part of our Brisbane Breast Bank. Thank you very much.
Thank you, Pete. That was a fantastic talk and really exciting data. Do we have comments or questions from the audience?
Hello. Hello, a very impressive talk. So I have a more general, but probably naive question. So you talked about the ductal lobular, like mixed type of cancer. So what is believed to be like how these type of cancer actually form? Is it like more plasticity, it transition from ductal to lobular, or is it a special type that just like intrinsically has both sides, or it's like more of a just a mixture? I'm just curious.
It's not a naive question. It's a good question. And so I think probably, and there's a number of pathologists in the audience that could will have their opinions, I'm sure. But I think there's probably subtypes of mixed ductal lobular carcinomas. From the work that we've done, the lobular component is clonally related to the ductal component, and perhaps it. So sometimes there's E-cadherin negative in the lobular component. Sometimes they're positive with aberrant staining, and I think the transition to that lobular component depends on whether there's an E-cadherin mutation, perhaps. Often there isn't an E-cadherin mutation, so there's some other mechanism which makes those cells become lobular or lobular-like. And it probably relates to how early on in the evolution of the tumor that mechanism happens. So most of the cases that we looked at didn't have LCIS. They had DCIS, ductal and lobular morphology. So the trajectory there would be DCIS to ductal, invasive ductal, to then a lobular-like differentiation based on some molecular mechanism.
Thank you so much.
Christine, please.
Thanks a lot for the very nice overview of everything that you've been doing. So regarding your point one, we're just happy to say that we could help if you want to.
Thank you.
Dr. Simpson, great talk. I had one question. Do you think these spatial data sets that we are generating, are they integratable, like single cell RNA-seq? Do you think different batches? Seems like you have a lot of data. So do you think there is integration possibility? So you can combine all these in future and then do more powerful analysis. So within DSP, and what do you think about Vigium? Could you combine? I think Vigium may be hard to combine with DSP given the platforms are quite different. But
yeah.
What about within DSP and maybe within Vigium?
Yeah, I'm sure within the same technology, there's a lot of scope for integrating specimens and data. We don't have very much. We're just getting going. So it's pretty exciting to be starting this new journey. But I think there should be a lot of scope for integrating or looking in your data set, for example, or I know that Christine and co have quite a nice data set too now, that we kind of look in different data sets for particular things that we found to be of interest, like SCOOP2 or something in mixed ductal lobular carcinomas. So certainly I think it will be probably a bit like other molecular data sets where we publish them in a compendium somewhere and they can be accessed by others.
Yeah, that would be quite exciting. Seems like there's more heterogeneity in the data set that you showed. There are regions which are intermediate, regions which are lobular-like, and NSTs. So it would be quite nice to have a compendium of data set where we can have more power and then look at each region.
Yeah, absolutely. Totally agree. Yeah.
Well, thank you, Pete. That was a fantastic tour de force. And our next speaker is Karen Van Velen from KU Leuven. Karen is a PhD candidate in the Laboratory of Translational Breast Cancer Research under the lead of Professor Christine Desmet. She is focused on the characterization of invasive lobular carcinoma, and she was the recipient of the 2022 Conquer Cancer Lobular Breast Cancer Alliance Young Investigator Award for the study of post-mortem tissue donation program. And she will share her insights with us. The stage is yours.
Thank you very much. You're hearing me okay? So thank you for the kind introduction, and also thank you for the organizing committee to give me the opportunity to talk about metastatic spread in patients with mixed ILC NST, so lobular and non-special type breast cancer, and the results from our postmortem tissue donation program. So when I was creating this, I wasn't really planning on referring to the baseball game, but it comes together nicely. So we know a lot about the NST. So patients with NST, we have a lot of background And so there's a clear view to the open field. For patients with lobular breast cancer, we're barely looking over the fence, but we're getting there. There's becoming more and more literature available. But for the mixed patients, for the patients with mixed tumors, yeah, we're still in the dark, and we have no view on what is going on. Well, what is mixed lobular and non-special type breast cancer? There are various definitions of it. The definition changed over time. So in previous reports, they talked about at least 50% of the tumor that had to be lobular. In 2019, this definition was changed, and now 10 to 90% of the tumor has to be lobular. Also, some studies did include the tumors that had a ductal appearance but with lobular features, or the other way around, while others were actively excluding them. So this makes it very hard or even impossible to compare results of the different publications. So we have limited publications, and it's very hard to compare them. But now we are using the 2019 definition of mixed lobular non-special type tumors, which means 10 to 90% has NST features, while 10 to 90% also have lobular features. When we go and compare these two non-special type tumors and to lobular tumors, we see that they align a bit more with lobular than with ductal. Bear in mind that this study was also done in for patients with tumors that were more lobular-like than they were ductal-like. So there were in those tumors more than 50% of most of those tumors, more than 50% of the cells that were lobular. But we see that the tumor size is more comparable to lobular. The age of diagnosis is somewhere in between lobular and I'm just going to use ductal for the speed than the non-special type. And when we look at ER and HER2, it's also more comparable to lobular than to NST. Grade was also significantly more grade 2 than in comparison to ductal tumors, and there was significantly more grade 3 in comparison to lobular tumors. Heat map was made to see the concordance between different types of tumors, so the ductal versus lobular, ductal versus mixed, and lobular versus mixed. Green means that there is a high concordance for that feature. Red means that there is a very low concordance for that feature. And here again, you see that lobular and mixed are more alike, that there is a higher concordance for all these features. In the study that was performed by Steffi's team, we also they also looked at the metastatic spread of these tumors. And there we see also that there's a comparison with lobular tumors, so that there's also more spread to the ovaries, to the uterus, to the peritoneum, and to the pericardium, which is less often seen in ductal carcinomas. Considering the outcome, there are conflicting results. So some say that there is a worse outcome, some say that there is better outcome, some say that there's no difference in outcome between mixed, lobular, and ductal carcinomas. This study was done by Otto Metzger, and he reported that the disease-free survival of mixed was actually a bit better than those with lobular, although not significantly. So there was a trend, but it was not significant. What they did see was that the grade of the tumor was not prognostic for lobular, but it was prognostic for the mixed tumors, as you can see on the right. So B is the are the mixed tumors, and A are the lobular tumors. Another report by Zeel, they did not see any significant impact on the histological subtype on survival outcomes. They used the SEER data, so they had a lot of data. They did say that the mixed and lobular carcinomas did a bit better than the NSTs, especially in postmenopausal women. And they matched the populations for a lot of other features. And so in postmenopausal patients, there was a significant result, but overall, there was no differences in outcome between the ductal and the lobular patients. When we go to the molecular background, we already had a nice overview by Peter Simpson. So what I can add to that is that when we go and look to those mixed samples and we see at different levels, so mRNA expression, copy number variations, gene expression, that we can differentiate between ILC-like and IDC-like. So there are no features that are specific for only the mixed tumors. There are a bit of differences in which type of molecular scores you use to see if it's IDC or ILC-like, but we can differentiate between those two. And about 24 of the 88 mixed samples that were used here were said to be ILC-like by more than 2 of the molecular scores. And we've seen that all the tumors that had a CDH1 mutation, that they belong to the ILC-like tumors. We also had already a nice presentation by Dr. Shah on the intrinsic subtype heterogeneity within those tumors. So I'm not gonna go into detail on this, but yeah, we know that there's clinical relevance, that there is the heterogeneity and that it can cause a therapy dilemma in treating these patients with mixed lobular and ductal carcinoma. So we know a bit, but there's still plenty of missing pieces to have a nice overview on mixed lobular and ductal carcinomas. So hopefully we can help a bit with the post-mortem tissue donation programs. I will discuss here now the patients that we've included in our program with mixed lobular and non-special type. Just a quick overview of what we do. So UpTiter is the UZK Leuven program for post-mortem tissue donation to enhance research. And our main objective is to unravel metastatic breast cancer evolution, biology, heterogeneity, and treatment resistance. The graph is just to illustrate that it's a logistic nightmare, that there's a lot to be done. Already before the autopsy, there's a lot of preparation that comes into place. We have to go to all the imaging to see where the metastases were located so that we can prepare. Once the patient dies, we transport her to the morgue as soon as possible. So we start the autopsy within a few hours after that. So that means also during the night, during the weekends, we are available 24/7. The autopsy takes about 6 hours. And of course, the weeks and months after, there's still a lot of work to do to analyze all of the samples, to clean the data, and so on. At this moment, we have 40 patients included in total. So that means all breast cancer subtypes. There were 2 withdrawals, and we've performed an autopsy on 30 patients. We had an autopsy last week, so it's not included in there yet. And we have 10 patients with pure ILC. That means that it's not mixed with any other subtype. And 8 autopsies have been performed. And we also have 2 patients with mixed lobular NST in the primary tumor, and both of those autopsies have been performed. And we are collaborating closely with the Hope for Others project here in Pittsburgh to see if we can add some more patients to the analysis and that we can review those samples as well. I'll focus now on those 2 patients with mixed lobular and ductal carcinomas. The aim was to do an extensive histological subtyping of the metastases to see if they were more lobular or if they were more ductal. So for each metastasis that we've uncovered, we've taken the samples, we've done the morphological examination and the E-cadherin staining. So if the E-cadherin staining, if there was a membranous staining that was complete, the E-cadherin was preserved, and we've called it an NST or ductal carcinoma. If the staining was incomplete, or if there was a cytoplasmatic staining, or if the staining was absent, we call that a lobular carcinoma. This is the first patient. So the core needle biopsy of this patient showed that it consisted of 60% ILC and 40% NST. So the blue arrows, they are for the zones of lobular breast cancer. So you see the discohesive cells and the absence of E-cadherin staining, while the green arrows, you see the nests of NST cells that are still staining for E-cadherin, so there's a preserved staining. I showed you the core needle biopsy because this patient was diagnosed at the age of 37 with an inflammatory breast cancer. So there was a need to neoadjuvantly treat her with chemotherapy. The core needle biopsy, they said that it was an NST with lobular features. We revised it for our program, and for us, it's clearly a mixed lobular NST. She had her neoadjuvant treatment. In the meantime, there was a germline panel up and running, and so they've uncovered that she had a BRCA1 mutation. So after the neoadjuvant treatment, she got a bilateral mastectomy and an axillary clearance on the right side. And they said that it was a triple negative NST. They didn't report on E-cadherin. It was done in an external hospital. And when we've revised the samples, then we've seen that it was completely a lobular carcinoma present in the breast and in the lymph nodes. She received adjuvant treatment under the form of epirubicin and cyclophosphamide and radiotherapy to the breast, to the thorax wall, sorry. After 11 months, she developed metastasis in the brain, leptomeningeal disease as well, and in the bones. She was treated with intrathecal methotrexate and citarabine, and because she was BRCA1 positive, talazoparib was given in maintenance, but it often had to be interrupted due to toxicity. After 14 months, she was progressive again in the brain and in the bones. PD-L1 was positive, so atezolizumab was started together with paclitaxel, but this worked only for 2 months, but again, progression, now also lymph nodes that were involved. The options were limited for this patient, so they tried to give the combination of all three, so the intrathecal chemotherapy, atezolizumab, talazoparib. But after 3 months, she was progressive again. Now, it was a patient that was really insisting on getting treatment. So they tried a cycle of cisplatin, but she was too weak to get any more chemotherapy. And sadly, after a month, she passed away. So we had some sites that were known prior to the autopsy. So we know that there were brain metastases, that there were metastases, so leptomeningeal disease, several lymph nodes, the pleura was involved, and the bone. And during the autopsy, we found some more lesions, as you can see here. And when we analyzed the samples, we've seen that the CSF as well as the pleural effusion showed malignant cells. And in the solid samples, we had 18 unique metastases, of which 61% was known upfront. Then, of course, we did the morphological examination as well as the E-cadherin staining. And what we've seen there is that every single metastasis had either absent or aberrant staining. So in the graph on the right, you see the percentage of cells per metastasis that had either preserved, absent, or aberrant staining. But yeah, you can see that in most of the metastasis, it was completely absent. In some of them, there were some cells with some aberrant staining, but it was clearly that all these metastases were lobular. Patient 2018, she had a primary tumor that consisted of 30% of lobular and 70% of non-special type. Again, blue arrows are for the lobular zones and green arrows for the ductal zones. She was diagnosed at the age of 47. It was called an NST with a lobular growth pattern, but again, on revision, we called it a mixed lobular NST. She had a mastectomy and an accelerated clearance on the right, and she had some adjuvant radiotherapy, chemotherapy, and endocrine treatment. She developed metastasis after 8 years, first in the liver and in the bones. She was started up with endocrine treatments, but she quickly progressed on her letrozole after 5 months. The addition of a CDK4/6 inhibitor with then fulvestrant only worked for 5 months also. Then she was started up with capecitabine that worked better. But after again 22 months, she developed additional metastasis in the lymph nodes and also in the fat tissue. And then several lines were tried, but always with only a limited result. 57 months after she got the diagnosis of metastasis, she passed away. Again, here we had several organs that we knew that they were involved. But again, during the autopsy, we had some additional findings. In the contralateral breast, in the adrenal glands, in the reproductive organs, and in the bladder. The liquid biopsies that we've done, so we saw that in the pleural effusion, in the pericardial fluid, and in the ascites that there were malignant cells present. And for the solid samples, here we had a bit more unique metastasis, but again, about 61% was known upfront. We've did the same thing. So we looked at the metastasis morphologically and with E-cadherin staining. And we saw a lot of metastasis with aberrant staining or with a combination of aberrant and absent E-cadherin staining. But again, none of the metastasis had any preserved staining of E-cadherin. So we only sampled two patients. It doesn't seem a lot, but all of the metastases of these patients, they were exclusively lobular. And this is actually consistent with what we see in the literature, that the mixed tumors are more alike the lobular tumors. So we do want to emphasize that it's very important that there is a good histological examination of the primary tumor, that we don't miss the mixed subtypes. Also, it's very important as clinicians to maybe go back to the primary tumor because the definition has changed. So we know that there are tumors that were called ductal with lobular features that might be mixed, and yeah, we can't miss out on those. And this also has implications for the clinical workup of those patients with mixed lobular ductal carcinomas. It has to be more similar to patients with lobular carcinomas. And in our institution, that means that there is a preference for whole body diffusion weighted MRI, as we've seen with the talk of Professor Van de Cave yesterday. So hopefully postmortem tissue donation programs can add some pieces to our puzzle, and maybe one day we'll have a complete overview of the picture. I'd like to thank my supervisor, Christine de Smet, all my colleagues of the Laboratory for Translational Breast Cancer Research, our collaborators, internal in the KU Leuven, as well as the external collaborators. Of course, I also like to thank the Conquer Cancer Foundation and LBCA, who provided me with my personal funding. And last but not least, I would like to thank all the patients and their families that were so altruistic to participate in this program and to offer their body to us, to science, to do this project. Thank you.
Thank you, Karen. That was a terrific talk, and congratulations on all this exciting work. Do we have any comments or questions?
Karen, that was great. Thank you for a beautiful talk and for sharing that data with us. My question is about the degree of confidence of calling the metastatic lesion based on histology, lobular. Certainly we have you elegantly showed kind of the aberrance, well, the high proportion of aberrancy or lack of E-coherent expression. But I guess I'm wondering about whether there is concern with the pathologist reviewing about, any treatment-related changes, considering the fact that she had gotten quite a bit, each of them had gotten quite a bit of chemotherapy. And, I know personally from, talking with our pathologists that there are certainly concerns about, how confident to feel about, how definitively you can call something really lobular versus ductal after they've received so many lines of therapy. So I don't know what the discussion was, and if you can comment on that.
Yeah. So yeah, we've in our institution, Maxime de Schepper has also been working on how we can improve the diagnosis of lobular breast cancer. So he showed you the results of the Cadillac study and the guideline that comes out of it. And of course, we have applied it also to our patients in UpTiter to differentiate between lobular and ductal.
Yeah, I think it's just a little more challenging because, certainly that may not take into consideration how that exact histology is affected by certain chemotherapies and, beyond kind of certain set guidelines. So, of course, there's challenges, but exciting to see this in where it goes.
That was very interesting. I was wondering, and I asked this before in the meeting, whether you'd have mutational analysis of the lobular component and the ductal component to get to the question of whether those could be two coexisting tumors as opposed to one disease.
Yeah. So the question was if we have the mutational analysis of the primary as well as the metastatic lesions at this moment to see if there was a collision of the tumor or it was two separate tumors. If I, yeah. They have the same mutations. Yeah. So we don't have those results yet. We're planning on doing that. The only problem will be a bit with patient 2015 because we only have that core needle biopsy that was showing the NST component. She had neoadjuvant chemotherapy. There only was the lobular left, so there it will be a bit harder to do the comparisons. But yeah, we're definitely going to do it for patient 2018. Yes.
Okay. Thank you so much, Karen.
Thank you so much. Two quick announcements. One is that I'm going to give it over to Dr. McGawler for the announcement of the awards from the poster session. And second, after that, it would be great if all the patient advocates could just stay in the room. I think that somebody is taking a picture of all of you. So thank you.
So this is a very exciting part of the program. I first wanted to thank all the judges who took the time to review the posters and to thank every single scientist who submitted a poster for evaluation. So our poster winners today are going to get a certificate, a trophy, and a Amazon gift card. And so in third place, we have ER interaction with MDC1 mediates epigenomic remodeling and gene regulation in ILC cells. Joseph Sotnick from Colorado, Anschutz from Matt Sikora's group. All right. In second place, we have coupling bioengineered microsystems with high resolution microscopy to investigate dormancy and drug resistance in ILC from Ohio State. That is Zilal Rima. And then in first place, overview of patients with ILC included in postmortem tissue donation program UpTiter, Christine Desmond's group. That is Gitta Zeist.
Good morning again. Welcome back to this penultimate session. Thanks very much. I'm Nancy Davidson. I'm from the University of Washington and the Fred Hutch Cancer Center. and I have the honor of overseeing this or chairing this particular session today. Now, this is a session that's called Case Reports. And we are really fortunate that we have 5 international experts who are going to bring to us for discussion patient stories, patients with whom they've worked. And you're going to know these are the most vexing patients, right? Vexing in the sense that the disease circumstances are so difficult. So many things that we want to talk about, and so many places where we think we can learn from it. You're going to know that the many, many, many men and women with lobular cancer who do well are not the people we're going to talk about today. It's the situations where we have difficult challenges, trying to think about how we can apply all this fantastic science that we've heard about to people. So today we have 5 different cases presented by 5 different experts. Rachel Jankowitz from the University of Pennsylvania, Dr. Kit Liu from UPMC in Harrisburg, Dr. Eleanor Sawyer from the King's College in London, Dr. Dhaval Mehta from UPMC in Monroeville here, and Dr. Chuck Geyer from the University of Pittsburgh at the NSABP. So you can see we're going to be able to see a variety of opinions from across the Atlantic, both sides of the Atlantic. We've prepared this to be interactive, so each individual is going to oversee their case discussion. They've set it up so they'll probably come to a point where there was a clinical decision that the patient and the doctor had to make together. And they're going to stop and they're going to ask for input. I think they'll welcome input from you in the audience if you want to shout something out. And also they'll take input from our panel here, but we're hoping to make this very interactive and not a didactic presentation of a situation that arose with a particular patient. So with that, our first presentation is from Dr. Rachel Jankowitz, formerly of this institution, but she moved across the state to the University of Pennsylvania.
Thank you, Nancy. And thank you again for the invitation to present. I'm presenting a case of triple positive ILC. This is what happens when you make your slides late at night after a clinic. So my patient, our patient now, because we're all going to give input, was 76 years old when she was diagnosed, extremely healthy at baseline for her age. No medical problems, essentially hikes all the time, very, very healthy. So 6 months prior to her diagnosis, she had had a screening mammogram and she had extremely dense tissue, which at that age is unusual. They saw a very slightly abnormal appearing lymph node on her screening mammogram and asked her to come back in 6 months later. So this is a picture of the diagnostic mammogram she got when she came back 6 months later. And you can see that there's just a very subtle asymmetry in the upper outer quadrant of her breast. It was very focal. She went on to get ultrasound, which showed a mass in that same location, and then unfortunately showed quite a few abnormal appearing lymph nodes at that time in her armpit area. So the pathology from the biopsy of her breast showed invasive pleomorphic lobular breast cancer, which was grade 3, strongly hormone receptor positive with a 95% staining for ER, 50% staining for PR. And then the tumor came back equivocal by immunohistochemistry for HER2 with a 2+ score, but it was positive for FISH amplification. So the tumor was called HER2 positive, but it was kind of an unusual FISH because, a lot of times when we see positive FISH for HER2, the ratio is greater than 2. But in her case, it was not greater than 2. She just had a really high average number of HER2 signals per nucleus. And so when you see that, the ASCO-CAP guidelines for HER2 testing kind of kick you into retesting mode to make sure. So I did that. I had them send her core biopsy to Penn because I said to myself, well, only 2% of ILC or so is HER2 positive. I want to make sure. So I had them send the core biopsy again, and we rechecked it, and we got the same thing, essentially high-grade lobular breast cancer, and it was the same issue where the ratio was less than 2, but the HER2 copy number was very high, so it was called HER2 positive. And the lymph node biopsy was also positive for a similar phenotype cancer. So she went on to get an MRI, which really showed the true extent of her disease. You can see on her MRI that the abnormal enhancing tumor is actually invading her pectoralis muscle, so it's involving her chest wall. And she also had very bulky lymph nodes in the armpit area. So I'm going to pause here, and this is an opportunity for questions. I presented her case at our multidisciplinary tumor board at the University of Pennsylvania, and the recommendation was made to give her preoperative chemotherapy with HER2-directed therapy, which often involves the TCHP regimen. But I wanted to see if anyone would have done anything differently based on that low level of HER2 expression yet. Any naysayers from the audience? Anybody not liking the direction this is going so far? She did not have evidence of distant metastasis, thanks. But to your point, Carrie, she had CT scans and bone scans, and she did not have anything else, but they were negative.
One comment. For these kind of triple positives where you get these low ratios and such, these are not the people who are in the trials. So this is always where we're getting beyond the database. And these are also the tumors where there's going to be heterogeneity if you look at across it when you get that variable kind of copy number. So I would definitely give this patient, start out with TCHP, but I would be watching, and this is a kind of person where I'm not sure what I've got exactly. So if there's not really the brisk regression that I like to see, we all like to see, I'll pivot to AC and get the anthracycline in like after 4, because these often don't respond as well as you'd like.
Yeah.
So, you know, the whole thing of the anthracycline from way back to the 006 data, the curves did separate, you know, and they didn't do quite as well on the TCHP. And when we see the stuff more current, it's probably these heterogeneity cases that where the AC might benefit. That's just observation on this kind of patient. We're kind of talking HER2 here, not lobular.
Right.
But this to me that trumps everything here when the systemic therapy, when you've got to make sure you're taking full advantage of any HER2 staining that is there. So agree with the TCHP, but I would do the wrinkle in the middle personally.
Yeah, and just to be clear, we did redo another slide from the same core biopsy, and we got a very, very similar result to what the outside hospital got. But yeah, you know, you're feeling unsure at this point. Adrian?
Rachel, I never understand in these cases why you don't give endocrine therapy as well, given it's an ER positive lobular. Why do you not give endocrine therapy at the same time?
So she will get endocrine therapy post-operatively, which will be a huge part of her care, but you're asking why we don't give it preoperatively. So, you know, a mainstay of treating HER2 positive breast cancer is with preoperative chemotherapy in combination with HER2 targeting agents. And we view HER2 as such an important target that, you know, that's where we focus our efforts. We don't normally give concurrent endocrine therapy and chemotherapy at the same time. That's sort of a long story, but it stems back to older trials. With the exception of, we now know it's safe to give ovarian suppression in patients who want to maintain fertility during preoperative chemotherapy, but short of that, we don't usually combine the two approaches.
The time, Adrian, is this functioning okay? Yeah, at the time, Adrian, when some of this came up, I think there were a couple of things. One is there was worry about overlapping toxicities. And in particular, for some of the endocrine drugs, maybe not so much AIs, but for tamoxifen and chemotherapy, there were more clots. So people were pretty concerned about that at the time. And you will remember way back when there was a lot of interest in the laboratory about whether or not there were some cell cycle reasons why you might not want to do that. But I think that's just sort of survived over time. And I would say maybe in the era of AI, we probably should, you know, rethink this, and we just haven't.
But Mo Ramawi led a study for NSABP B52 that looked at that TCHP for 6 with TCHP ovarian suppression AI, maximum suppression, really no difference in PCR, a tiny bit numerically higher, but not statistically different. So it doesn't look like you're not harming, but you're not gaining. So
that wasn't in lobular.
No,
Okay.
no, you are positive, but I mean, yeah, but
All right.
that's the
Well,
best data we have.
I better move on because so anyway, you see my conundrum. Okay. So we started TCHP and actually it looked great. You know, it started shrinking on clinical breast exam. The tumor got smaller. Her lymph nodes were palpable and they got smaller. So I'm thinking good, you know, and then I get her post chemotherapy MRI. You can see there's improved non-mass it wasn't gone, but it looked better in the breast and in the lymph nodes. But I knew she was going to have residual disease, but it did appear to be a partial response. There was now a fat plane. This was important between her pec muscle and the malignancy, so enabling surgery, which again is one of the goals of preoperative treatment. So unfortunately, she had a left-sided mastectomy, axillary lymph node dissection, and there was a fibrotic tumor bed, and there was residual cancer there. It spanned 4.8 centimeters, but you did see therapy-related changes, so she did respond. And then there was multiple smaller foci of invasive cancer in every single quadrant of her breast that was removed. The tumor cellularity was 40%, and 13 out of 13 sampled lymph nodes had cancer in them. So the cancer, and this is often the case, was now hormone receptor positive, and now it was HER2 negative on the residual disease, which happens almost 50% of the time, actually, that it does appear HER2 negative after preoperative treatment. But the question is, now what do I do?
Radiotherapy here, and then you're thinking more about the systemic therapy.
Yeah, I'm thinking, of course, as the medical oncologist, she clearly needs radiation for local control. As the medical oncologist, I'm thinking, what am I going to do in the adjuvant phase? And we normally do give TDM1 for residual disease after preoperative HER2-directed therapy. And I'm not going to read every one of these bullet points, but on subsequent analyses of the Catherine trial that compared TDM1 to trastuzumab in the adjuvant setting, the TDM1 benefit compared to trastuzumab was not affected by the HER2 gene ratio or copy number. And, to make a long story short, the 3-year disease-free survival was similar for patients with a high IH 3+ score and those with a 2+ score, like my patients had. And an analysis of the effect of the TDM1 seemed to imply that the TDM1 was overcoming resistance in patients. When you looked at the effect of the HER2 gene expression levels, high HER2 gene expression was associated with worse outcome, but it was in the trastuzumab arm, but not in the TDM1 arm. So it kind of implied that TDM1 was somehow overcoming resistance. So we don't usually change ship, just because the tumor converts to HER2 negative. We usually do offer TDM1. But in this particular case, I was still wondering to myself, was she ever really actually HER2 positive in the first place? And what should I do now?
So, Rachel, my question is, did we repeat the HER2 new back on the surgical path?
The HER2 what?
Did we repeat the HER2 new? If we are worried about the HER2 new heterogeneity on the surgical path, did we repeat the HER2 new, especially on the lymph nodes when she had 13
It was, yes, that's a good question. It was negative on both the lymph nodes and the surgical specimen. It was 1+ on both after treatment. So I wanted to know, how often did this happen on Catherine, actually? And this is in the supplement to that paper. So how often did the tumor become 1+ after neoadjuvant therapy?
And it wasn't actually that often. You can see in the third line down from the table that for whatever reason, the 1+ is, the percentages are in parentheses there. So after neoadjuvant treatment, it only became 0 or 1+, 6% of the time. So
we need to keep moving along.
Okay, so anyway, that's the end of my slides, but
actually, the question is, what did you do? I would be thinking not only, we give the TDM1, which I think we'd all agree with. Yes, I think.
I would add, the NSABP B60 protocol, which is, randomizing, FAM TDXD compared to TDM1, because we know, at least on a metastatic setting, that it has activity on HER2/neu 1+ and 2+. Again, granted, it's a randomization, but that would be my choice to this patient, apart from continuing endocrine therapy as well.
So my question is for the group and to you too. You mentioned about the TDXD trial, but there's also the Compass HER residual disease trial that incorporates tucatinib combination in the adjuvant setting, especially with the HER2 kind of variability. I just wonder about, is there a HER2 mutation that's occurring here? Would a TKI be more effective than a TDXD or ADC? So that, I don't know if we know that answer, but perhaps considering Compass HER2 trial would be another option.
yeah, so we have that study open. She did not want to participate in that trial, but it is a combination of TDM1 and tucatinib compared to TDM1 alone. My real question was about her adjuvant endocrine therapy and whether anyone would offer her abemaciclib despite the low level of HER2 positivity.
I think that's what I think I would go for the TDM1, do that, and then 2 years of abemaciclib, although there's no trial to support it.
Yeah.
I'd have to say I was in the same camp. I would be thinking you'd be heading towards an aromatase inhibitor. I probably would try the abema. And the question is how you integrate that with that TDM1, very complicated. And then I also think that, there is information about bisphosphonates in this setting. And so you could think about all those. So what'd you do, you and the patient?
So she is on TDM1 and she is going to finish out the year of TDM1. And then I'm going to start abemaciclib with her adjuvant aromatase inhibitor. We don't have data to combine it with TDM1, and I was afraid the cytopenias would be too much, and we don't really have safety data for that. So,
one question in the back.
Just be devil's advocate, but would you consider neratinib since it's triple positive? And again, because of the fact that it would, potentially have a role with there's HER2 mutations as well.
Yeah, I've done neratinib when patients have inadvertently gone to surgery up front, and we didn't know how much disease they had, and then they come back with advanced stage triple positive disease. I haven't done it after TDM1 because we don't have as much data in that setting. But yeah, the advantage was more prominent in triple positive patients, and that's certainly an option too. But weighing how weak her HER2 signal was, I thought it would probably be higher yield to do the abemaciclib than the neratinib. But of course, this is all just conjecture. So,
all right, thanks very much. Great discussion.
One more comment. Wait.
Up. Last word from Dr. Geyer.
Just another comment. When you check the HER2 after neoadjuvant antibodies, you probably should go back and do FISH if you want to really know what it means, because the antibodies are supposed to make the expression go down. And so going from 2 to 1 isn't really much of a change. And that's part of why going negative, particularly when it's that way. But we did look at what if it's also FISH negative, and the benefits were still there. And it's quite striking. It was in your slide. Yeah, you didn't have time for it, but it was not a small, it was like, in patients that got trastuzumab, 70% were free of recurrence. The TDM1 was waiting for its first recurrence. So there was a big difference. So it wasn't like uncertainty. It was really pretty clear. The other thing on this one, because I was kind of thinking about the neratinib question too, how would you pick? This might be one where I might want to look for a mutation. since it's a lobular patient, and if there's a mutation, that would tip me over to neratinib.
I think that's
Just,
Eleanor's point.
Yeah.
Yep. Excellent. Really interesting discussion. Older patient, a lot of therapy, very interesting biology, not what we necessarily expect, which has driven a lot of our decision making, and hopefully in conjunction with her. It sounds like she wanted to be very, very intensive and deliberate about her therapy and has tolerated quite well, it sounds like.
Yeah, she did. She did remarkably well with the chemo.
So we're going to move on to our second presentation from Dr. Kit Liu. Dr. Liu.
Thank you, everyone. And thank you, Steffi and Adrienne and the organizers for the symposium. I think this is my first attendance, and I really enjoyed the symposium. It's really unique to have translational medicine, patient advocacy, and then have the esteemed colleagues to help me with this case presentation, because I'm seeing this patient on Monday. And so I really hope to give her an answer by Monday. No pressure here, no pressure. So I have a younger patient here. She's 48. She's a very, very lovely lady with 2 young teenagers. And this was an unexpected finding. So I'm hoping to give her a good, plan of care. So she's premenopausal. She initially noticed a lump in her right breast that was slowly grown over a year. And as many young ladies, they kind of just chalk it up as, maybe this is a normal part of my body. And she kind of let that grow over the last year. But then she started noticing some changes to her nipple and her skin. And she eventually went to see her GYN for a wellness exam. And the GYN had felt a pretty large size mobile mass in her breast and sent her for a mammogram. Very healthy otherwise. There's some family members with cervical cancer and breast cancer. And this was her initial diagnostic mammogram, 3D mammogram, that basically showed a very large area of architectural distortion involving the subareolar region. And there was additional areas of indeterminate calcification. This was the ultrasound, and ultrasound actually was very inconclusive because it was just too big to ultrasound. But there were some cortical thickening in the axillary lymph nodes. There was some incidental finding on the left breast as well. And this is her breast MRI. And what they found was a rapid enhancement in the subareolar mass on the right breast. And the nipple was contracted. There was nodular skin enhancement. And there were numerous lymph nodes with extensive cortical thickening. On the left, there were some, not shown here, but on the left, there were some multifocal enhancements that were seen and not found on mammogram. And these were her biopsy results. So she underwent a right breast needle biopsy, which showed a classical type invasive lobular carcinoma, strongly ER positive, PR positive, and then HER2 IHC0. Ki-67 was 5%. And her right axillary lymph node was positive for metastatic carcinoma. On the left, there were a couple of areas of concern, but they turned out to be non-malignant. So over the initial course, she underwent genetic testing, which showed she had a germline BRCA pathogenic mutation. So, for the purpose of time, I'm going to kind of just go over her treatment course and my current dilemma. So we did offer neoadjuvant therapy, including chemo and endocrine therapy. And ultimately, she decided that she wanted to pursue surgery first. She underwent a bilateral mastectomy and had underwent a right axillary lymph node dissection. This was her final pathology, again, showing invasive lobular carcinoma, classical type. It was multifocal, with the largest foci being 6 millimeters. And you can see the other measurements here: positive lymphovascular invasion, dermal vascular invasion. And surprisingly, or maybe not surprisingly, she had 10 out of 10 lymph nodes that were involved with extranodal extension. Ki-67 again was 5%. And her pathologic staging was stage 3A. So at that time, she underwent a staging evaluation with the FES PET scan. And there was no overt evidence of metastatic disease. There was a very subtle uptake in the right fourth rib that the radiologist had questioned whether or not this was inflammatory versus post-traumatic, but really no other evidence of disease systemically. What would you call it? Okay, that's good to know. So she ultimately underwent adjuvant chemotherapy with anthracycline-containing regimen. She also completed radiation. And at this point, we discuss ovarian suppression given her premenopausal status, although she is 48. And she elected to do an oophorectomy along with an aromatase inhibitor. And then we also discuss using olaparib because of the BRCA mutation, and also considered the CK4/6 inhibitor as well. So she underwent her bilateral oophorectomy, and surprisingly, they found a metastatic carcinoma compatible with breast primary. So this was her pathology report. It was 3 millimeter focus. There was no other area. She had a pelvic washing that was negative for malignant cells. The receptors here was ER positive, PR positive, HER2, IHC 0 again, and Ki67 at this time was 20%. That's a great question. I don't have that. Do we have the images of the PET exam? Okay. Mm-hmm. Okay. Well, so we actually repeated another FES PET scan after the results because we were surprised with the finding. And this was about 6 months later after her adjuvant therapy. So we wanted to make sure she didn't develop metastatic disease during the course of her chemotherapy as well. And so there was no findings of any evidence of metastatic disease. The radiologist mentioned there was actually an interval resolution of that right fourth rib uptake, which again, in retrospect, was this metastatic or not? We don't know. They also mentioned that there were additional non-specific sclerotic bone lesions in several areas. When we did our multidisciplinary, yeah. So the question was these findings of the bone lesions new? And when we reviewed at a multidisciplinary conference, the radiologist, in retrospect, saw maybe some sclerotic lesions, but not, it did not light up on FES. Yeah. No, treated. So yeah. Perhaps new treated.
New sclerotic osseous lesions on the follow-up exam would be a slam dunk. Those are Mets that are being treated. So knowing whether they are stable from the old exam or new from the old exam would be a critical piece of information.
Yeah, so what the radiologist mentioned was this was treated, and perhaps new because it wasn't evident.
This was after chemotherapy.
This is after chemotherapy. Not yet endocrine therapy. So here's my dilemma here. She was initially diagnosed with stage 3A, but now upstaged to stage 4, technically, right, with an isolated, metastatic cancer in the ovary and questionable treated sclerotic bone lesions. So what is our intent of treatment here? And if our intent is palliative, are we committing her for a lifetime of endocrine therapy, CK4/6 inhibitor? Do we do both? Do we do PARP inhibitor and CK4/6 inhibitor, or should, because of her germline, should we just give her a PARP inhibitor? And what is the optimal duration of treatment? or should, and also not included here, should we survey her with ctDNA, given many excellent talk at this session? So
Rachel, and then Gabo, if you want to give your opinion, and then we'll move on. And actually, then we'll hear what you're going to do.
I mean, I think it sounds like she has metastatic breast cancer. She has treatment emergent bony metastases. She has biopsy proven metastases to her ovaries. I would do first line endocrine therapy with a CDK4/6 inhibitor and reserve the PARP inhibitor for progression. That would be what I would do.
I would echo Rachel's comments and add bisphosphonate for sure, but and reserve a PARP for future.
My only thought was about the adjuvant chemotherapy. Once you found that she had disease in the ovary, did she need to have the adjuvant chemo? Could you just gone to the?
It was after the
Okay.
chemotherapy.
Yeah. Okay.
Yeah.
So she too late.
It was a little too late.
So what are you going to do?
Well, that's what we talked about. We talked about, giving her CK4/6 inhibitor, endocrine therapy, and then reserving the PARP. I guess, the dilemma is she doesn't have any evidence of disease at this time at all, and there were several in our group that talked about maybe giving her the benefit of curative intent and giving her a year of PARP inhibitor, given the Olympia A study showing improvement in survival, and then switching to CK4/6 inhibitor after that 1 year. Would that be a reasonable option? No. Okay. Okay. Yeah.
All right.
All right.
Well, thanks very much.
Sounds good. Thank you. Sounds great. Thank you.
Okay, great. Well, thank you very much for asking me to come to this very exciting meeting and talk, and it's been a great few days. So this is a very difficult and sad case that we had at Guy's. So it's a 37-year-old lady who basically presented with 4 weeks of tiredness and shortness of breath, as well as gum bleeding and heavy periods. Went to see her GP and was found to have a hemoglobin of 65, platelets of 46, so very low. She'd had surgery to remove a fibroid 3 months earlier, had perfectly normal blood tests, and she did have a family history of a grandmother and an aunt who had had breast cancer. So the first thing she had done under the hematologist was a bone marrow trophine, and surprisingly what they found was that she had extensive infiltration with lobular breast cancer. So this was ER positive, PR positive, HER2 negative, E-cadherin negative. Clinically, there was no obvious breast mass. Obviously, we did breast imaging, and she had very dense breast tissue, which you can see here, and no obvious primary on the mammogram or the MRI. But she had complained she felt of some distortion of the upper outer quadrant of the right breast. So we ultrasounded it. There was some distortion. It looked benign, but we biopsied it. And indeed, she did have invasive lobular carcinoma, grade 2 classical type. So this was her staging and really didn't show anything very remarkable apart from this very kind of diffuse sclerotic lesions in the vertebra. Her bone scan was normal. So I guess my question to the panel is, what would you do as her first line of treatment?
So her counts were pretty low. Did we perform a bone marrow biopsy?
Yeah, so we did a trophine, yeah. So I guess we know now that she's got bone marrow disease only, but what would be your systemic therapy choice?
I mean, she is kind of in a what we call visceral crisis, and I would be leaning towards a more chemotherapy directed approach to start. At least now that though we have a data, in ASCO and San Antonio, that AI plus CD4 CDK inhibitor, even in visceral crisis, have been doing very well. So I think if count is not an issue, means you could try that would be also a reasonable approach.
So we were brave and we went for ribociclib, letrozole, Zoladex, and denosumab. And sorry, you can.
Right. Yeah. That's, yeah. I would have been nervous about the ribo, but you feel like you got to try it and see what you can get away with, which is what I assume what you did.
Yeah.
Yeah.
Good. So, as you would expect with a CDK4/6 inhibitor, not a massive improvement initially, but her platelets gradually improved. Her CA-153 dropped from 6,000 down to 1,000. During this time, she had germline genetic testing, was found to have a BRCA mutation, and she remained stable for the next year until the CT scan revealed these very tiny little new liver met. And so we were in the point then that we needed to change treatment again. So again, to the panel, what would you do next? No, so it's literally that tiny. I mean, I haven't got a pointer, but it's tiny.
So I would then consider a liquid biopsy to see if there's any potential ESR mutation, in which I would consider, a SERD, either, with IM or oral SERD. There's studies in terms of the MAINTAIN trial, whether or not we should continue with CK4/6 after CK4/6, given that this was only 3 months of treatment, right?
No, she'd had a year. She'd had a year.
Over a
she'd
year
been
of stable
for a year.
disease.
Yeah.
I would consider maybe maintaining on a CK4/6.
Yeah. So we were actually quite keen to start her on olaparib because of the BRCA2 mutation, but we are in the UK, so nothing's quite as easy to get a hold of as it is over here. But they told us that we couldn't because she'd never had any chemotherapy. So we then went to weekly paclitaxel, which actually worked very well. Her CA-153 can write down to 400. She, remained stable for another 9 months. And then on the regular staging scan she was having, there was this suggestion, and the radiologists were kind of hedging their bets a little bit, that she might have some progression in the lung and liver. We should do a PET scan. We didn't see anything on the PET scan. We did an MRI liver. We didn't see anything, but her CA-153 was starting to rise. So I guess the question to the panel now is, would you carry on with the same treatment, or would you switch, and what would you switch to?
Yeah, I guess I treat through rising 15-3s. I try to tell patients, if we're following this, it's going to go up. I use a lot of analogies. And to me, with what helps patients understand this is you have metastatic disease. It's incurable. We've got a bunch of therapies we want to use in sequence. So think of the Pony Express. I want to ride every horse until the horse drops. I don't want to jump to a fresh horse because I'm not going to get as far. So I have no idea if there's any scientific validity to that, but it helps people understand that let's wait till we see something worse. Now with ctDNA, we can, and if you start doing CTCs, that might be a trigger, particularly if there's something appealing that you want to get to next. Because again, it's always that tension of, for me, when all we were doing was non-selective chemotherapy, what's the rush? But as you get into these targeted therapies, it might really keep the mass from growing back, because I assume you knocked it back pretty good with the initial therapy. So to me, it makes sense to try to keep the tumor still and not dividing and growing and spinning off all this complexity. So to me, but it's always been difficult to know. That's why I think the ctDNA stuff really helps to know what's going on.
Rachel.
I mean, I think another important thing to go into that decision-making is how the patient's doing and how her blood counts are doing. So in these patients with non-measurable disease with a lot of bone marrow involvement, if obviously her counts were in the toilet in the beginning, right? And if they stabilize with therapy, that goes into your decision making. Are they dropping again? Are they dropping again at this?
Yeah, so I think she's had a lot of weekly paclitaxel now. She's actually a little bit fed up with it and actually quite keen to change. And obviously, what we really wanted to start, would have been to give the olaparib. So now we can give the olaparib, right? Because she's had some chemotherapy.
So asking the patient how she feels
exactly
is important.
So she was very keen.
Is your quality of life good on this medicine?
So
yeah, exactly. So she was very keen to get to the olaparib, which we'd wanted to do before, but weren't allowed to. So we now got that on a named patient basis, and she remained stable for another 9 months. And then things started to get out of control. We could now see after 9 months that the PET scan, she's getting small volume sites of active recurrence in the liver, paraortic, lymph nodes, peritoneal, and serosal. And so this is an FDG PET because we don't have access to FES. So we were getting now clear progression, and in the interest of time, I will move on. But we had quite a few options. We don't do as much liquid biopsy in the UK as you do here, but we did get a garden. We had a PIK3CA mutation. She actually had 2 PIK3CA mutations. So our options were we going to go for the fulvestrant and the PIK3CA inhibitor, or we also discussed the Rollo trial, which we were running at Guy's at the time, which was fulvestrant and crizotinib. And we also discussed just standard chemotherapy. But the thing that really swung us for us was that we did a rebiopsy, and now she was coming weekly ER positive. So the ER was now dropping. And so initially we were going for the fulvestrant and the crizotinib, or the fulvestrant and the PIK3CA inhibitor. But because of the change in ER, we felt that we needed to go for chemotherapy. She was really keen not to lose her hair. This was a really big thing for her. So we went with capecitabine. But unfortunately, within 8 weeks, she had lots of abdominal bloating, hydronephrosis, bladder distension, and had stents. Bladder biopsies showed now that she was actually ER negative and HER2 negative. So we were now triple negative. We started Saki, but sadly, she rapidly progressed with peritoneal disease, lots of hematuria, so really awful bladder disease and bone marrow failure, and sadly succumbed to her disease. But I think why I wanted to show this case was that we see this transformation to triple negative. And I think until I started doing the Rollo trial, I didn't realize how frequent it was. And I think it was Christine said yesterday when she was talking or answering one of the questions that about 60% of their post-mortem cases are triple negative. And I think when that happens, suddenly the disease is completely out of control. That's when we have real difficulty treating. And I think there is a session about what things we need to understand in lobular. And I would say one of the things is, what is it that makes this sudden switch into being triple negative? So thank you for listening.
Thanks so much for your discussion. I think the other point I took away is that sometimes it's regulatory situations that don't allow us to give exactly what we want to give. Like you said, you had to give chemotherapy before you could access a PARP inhibitor, which biologically makes no sense to us whatsoever, but is unfortunately the reality of how some of these drugs are approved. So with that, we're going to move on to our fourth discussion today, and that's with Dr. Dhaval Mehta. Dhaval.
Can you hear me? Yep. Okay. Again, thank you, Steffi and organizing committee for this opportunity. And again, I'm also seeing a patient on Monday morning, so no pressure, but I need some help for sure. I'm one of the community oncologists, practice in East Suburb here. So I have this very nice 53-year-old postmenopausal female who missed mammogram for 5 to 6 years. I met her, in fact, in September 2016. She had abnormal mammogram. For interest of time, it was a multifocal disease, right lower quadrant, right upper quadrant, 5, 6, 8 o'clock position. The biopsy, in fact, revealed a classical ILC, nuclear grade 2, noting ER 280. One of the was PR less than 1 with HER2 Ki67 of 10%. Other was PR was positive, but Ki67 20%. She had hypertension, a little bit of depression, anxiety. That's definitely got worsened during this diagnosis time, and in fact, she had the borderline diabetes at that time. I'll come back to why that matters in the future. And she had one side oophorectomy due to unrelated cause in a young age. So in terms of initially at that time, she has clinically and radiologically node negative. This was more felt a luminal phenotype. but she had, multifocal, multicentric disease at that time. And, again, this is, 2017. And I want to just ask, surgical colleagues. I know we have breast surgery colleagues. We had wonderful sessions this morning, but there was upfront, modified radical mastectomy and axillary node dissection was happening. But do you offer upfront immediate reconstruction, in a lobular variety? That would be my one question. At your institution?
Yes, we do offer immediate reconstruction for patients with ILC.
ILC, even and mastectomy, and as long as they are clinically radiologically node negative.
I think that I'll let Dr. McCullough talk about this.
So with her being clinically node negative, an option for her would be sentinel lymph node biopsy and then getting an assessment of those results to make the decision rather than going with immediate axillary lymph node dissection.
It's again, this was a very thoughtful decision. Again, interest of time will go through. She had recovered reasonably well, but this was a, tram flap, from an abdominal wall, unfortunately had some infection, required debridement. Her borderline diabetes also didn't help us. But that delayed some adjuvant options for 3 months. Unfortunately, Pat, as Dr. Mukhtar showed in her case in the morning, surgical path was much more upstaged with invasive lobular carcinoma, which was 7.5 centimeter. She had lymphovascular invasion, high-risk features, though margins were negative. It was involved in 3 out of 32 lymph nodes, 0.5 centimeter, no extracapsular extension. So was thought to be clinically high risk. At that time, staging scan and a bone scan negative. She comes, she's now in November because it was started in September and journey came in November. My question to the panel here, at this point with this path, what would you do? She's 12 weeks out technically, but we still want to go for curative intent. Anybody, Chuck or?
I know there's been a delay, but I think you have to ignore the delay and just treat her as you would have done if there wasn't a delay. These things happen. We can't change our standard patient management for them.
Therapy trials allow a window of up to 4 months. So,
okay. Yeah. So we did the genomic, testing at that time. She was Mind Atlas data was just coming out right there. She was deemed MemmaPrint high risk. Certainly with at that time, MemmaPrint, data was with the Mind Atlas, with the combine of endocrine as well as chemotherapy up to 88% survival. This was so in April, we finished 3 months of treatment. The reason we couldn't go up to 6 months was some of our neuropathy got worsening, and there was, the wound that the plastic surgeon wanted to be very careful because it took us a while. So she finished 3 months. Our intention was up to go, and that's one of the reason we we didn't choose ACT and had to have to choose the TC treatment. She also got breast and nodal radiation. At that time, we had access to PALAS study. So she did participate in the PALAS study. Our goal was adjuvant AI and she was in fact randomized to the experimental arm, and she received 2 years off Palbo and finished, August 2019. So my question to the panel here, anything you would have done different in 2023, other than, now we know PALAS data was not, disappointing, but Obama has, better.
Shout out to you and this patient for 2 clinical trials. Good job, both of you, contributing to our knowledge base.
Yeah.
Did you do genetic testing in terms of
At that time, she did not had any family history. She was postmenopausal, but certainly we have done, down the line. Yeah. So go ahead, Rachel.
Yeah, I was going to ask the same question. She was postmenopausal.
Postmenopausal.
Yeah. Then the only thing I would do differently now would be the abemaciclib.
Yeah. So again, the reason I'm putting this little tumor marker stuff was because she, usually it's not, if they are node positive, at least in community, I check once, and if they are elevated, at least it gives me some. This is before, now we are learning much more CTC, much more ctDNA that I can do in clinic. So she was elevated, and during the, PALACE program, at least it did came down. She was continuing at UNAI. She was doing completely well. She was, in fact, on a cruise, went to Galapagos Island. And last September, her tumor markers started rising. And I get a frantic call when she had this tumor markers goes up, which is, 156, 177 in September of 2022. I asked for a PET CT at that time. Unfortunately, insurance declined. I, in fact, had a peer-to-peer call. They will not allow. It was even just a standard PET CT, FES. That, in fact, the insurance call. Yeah, because even the, I tried to even give some Seriana data. That was, they said, go for a staging CT scan, bone scan. That was, in fact, no evidence of disease. Tumor markers continue to rise. Finally, we got the PET CT approved after a staging CT scan. We, in fact, also did at that time MRI breast, just because she had immediate reconstruction. Tumor markers were going up. We wanted to make sure that there is not something, going over there, which can explain. And she did show multifocal osteolytic, bony mets in pelvic bone and left scapula. So again, whenever my question, I think we have talked about imaging insignificantly, but I wanted to ask a panel or an audience that have you had experience, or at least insurance-wise, letting you allow Seriana or FES PET upfront in a metastatic? Have you seen challenges, or, hopefully we can continue to see advocacy work?
I'm going to guess everybody at this panel, except for maybe you, Eleanor, because you don't practice in the United States, has run into that repeatedly. So one question I have for you is, how did the patient feel physically all during this time? Was she asymptomatic?
Asymptomatic up until time. Now, as we start digging up more, she was having some shoulder pain that she noticed. She initially, when we digging it up more and more, then she would say that I thought I was my rotator cuff, but turns out to be a scapular mat. So the biopsy was performed, was metastatic breast cancer. Now she's still ER positive, but PR is negative. HER2 new, why my pathology was 1+, not amplified by FISH. Ki67 was 25%. And we performed the molecular studies right there. Sorry for this is, a little bit there, but definitely patient had ERBB2 mutation and a PIK3 mutation, and TMB was 13.3 with 80th percentile. Just, I think, really echoing what's have been the last few excellent presentations, which are, suggesting. No, this is tissue. This is tissue at that time. And I also did liquid, which showed the concordant PIK3, but had showed a little bit of BRCA2, which was 0.1%. So we did the hereditary panel to confirm, but there was no BRCA at that time. Sorry. Yeah. Yeah, it wasn't there. So that's my question, which is the driver mutation, and which, I want to consider for, the molecular targeted treatment at this time. And so go ahead.
Just a quick question. Do you remember what the allele frequency was of the B2 mutation?
Sorry?
The allele frequency, how frequent
in the liquid.
No, yeah. I don't think it
Uh,
doesn't say. So
Unfortunately, they
They don't tell you.
Yeah,
Okay.
they don't tell us. This
That
is
would
our yeah.
Yeah, okay, because I guess that would help you answer
Yeah.
that question.
In the garden, it was 0.2 the liquid biopsies, but certainly this one we do not get that.
Yeah, I guess the interesting thing to me in this kind of case is the TMB.
Mhm.
You know, when because it's always when do you pull the IO trigger?
Mhm.
Because you're seeing everything you're going to treat this patient with. So I'm picking sequence, not like early where I'm having to choose my therapy. I'm picking sequence.
Mhm.
And I guess I bought into that idea that if you're going to do IO, do it early
Mhm.
while the patient's immune system is its most robust.
Mhm.
The challenge is on a patient like this. So if I'm going to give IO, do I give IO with a targeted therapy? Do I give IO with chemo? So I'm going to move up chemo earlier because I'm doing IO. So, probably that's what I would do. I would give a weekly. She had neuropathy before, so I can't give taxane. She's got neuropathy.
She's
So,
recovered right now. This is right now. This is a progression on AI. So I'm just talking. Yeah.
Yeah. So
Just,
I mean, well, that's the question. Do you go because generally in the absence of the TMB, I guess I'm still change the endocrine therapy and let's get what we can out of CDK4/6 before I start doing the targeted therapy. I noticed that Massimo differs. He likes to see the targeted therapy and jump right to it from what his presentation was earlier. But I'm still the data from the CDK4/6 inhibitors. It's broad based. I tend to go with it first, but this gives me a lot of uncertainty about which to do. But I probably would wind up leaning towards doing Pembro personally.
What did you do?
So first, we had long discussion with the patient. We focused PI3 kinase, ERBB2 mutation, as well as IO. I said I have multiple options here. At that time, we switched her to SERD for the fulvestrant. Plus, we looked at the abemaciclib at that time because her Pallas-wise, she got almost Palbo was stopped almost 4 years ago. She wanted to travel. She wanted to take a dose. She had to come once a month. She said that I would try the pills, and we gave the bisphosphonate as well. Our tumor markers, as you can see, has just kind of stayed stable, but in fact, now it started rising. And as a matter of fact, I checked last night and it is up and she's coming Monday morning. So she had a little bit of worsening pain on her scapula and we salvaged with the radiation. She's improving. I again tried to get FAC, Seriana PET. Unfortunately, they didn't decline, but at least I got the PET CT this time, which was showing a decreased activity. So I have now rising tumor marker with potentially ERBB2, PIK3 mutation, and a borderline diabetic patient who has otherwise bone-only disease. Fulvestrant plus abemaciclib has bought me some, as I loved your analogy of Pony Express here, and I'm continuing to drive the pony. And so my question to the group is now with this rising tumor markers, though with stable scan, would you add IO? Would you switch to Faslodex plus PIK3 kinase mutation, or and reserve the ERBBT mutation drug for future?
Again, how's she feeling?
She is feeling stable. Her pain is improved, but she is very nervous with her tumor markers continues to go up.
How long from the previous garden? I might buy time by updating that and seeing what's evolving.
Yeah, so her it was in February, so I haven't done any CTC.
I might look again since my markers are going up just to see what the current problem is, but wait for that to make a decision. Hopefully, it'll point a path, show the door that we should knock on. And maybe Cappy will get approved and you won't have to deal with alpelisib. So
I agree. I wouldn't rush in and do anything quickly. I mean, if you do another garden, you'll see if you see that B2 mutation, which would give you another option. And as you say, you might be approved, and then you don't have to deal with the diabetes.
I would agree. I think if she's feeling great, I think one of the dilemma we have as treating oncologists is like treating the lab versus treating the patient. And, I rarely do the tumor markers for that reason, because, I don't know what to do with the results if there's rising and then the imaging shows stability. So I would follow the patient, maybe do a closer interval scan and then do a garden as the others have said.
Deval, I wouldn't forget about the BRCA2 mutation. So Ethan Sokol presented earlier in the meeting that that's not uncommon to have a somatic BRCA mutation. We have a case we just reported last year that's very similar. A lobular patient who progressed on AI with bony mets, had picked up a somatic BRCA1 mutation, and organoids from that was very sensitive to talazoparib. So I would repeat, if you repeat the Guardant, you may, and that's going up, that may give you another option as well.
Here's the last comment.
Yeah, I like the idea of repeating the Guardant too. And I think what I say, my pony analogy is treatment of metastatic breast cancer is a marathon, not a sprint. And there's sort of a triad of things you're looking at, with the patient being at the top, patient scans and whatever circulating marker you're using. But Alpelisib is a difficult drug to use, and I think your patient has elevated blood sugars, right, Davil? So that's going to be real hard to do. And you could try after prior fulvestrant, but I like the idea of waiting for the other capacitor.
No, thank you.
And Davil gets one last word, because having worked with his patient to do 2 clinical trials, he's proposing another one.
Yes. Yes. So this is the trial. Thank you, Dr. Foley, who shared me, but this is what I already told the patient, because I told the patient that I'm going to keep you going on a trial on multiple. I was looking for ERBB2 mutant trials. So I told the patient that we're going to have 7 trials and 14 options in future. Thank you.
And Dr. Geyer is going to bring it home. Chuck.
Okay, well, I'm going to shift gears a little bit, and I guess go to a more regular problem that we do see with lobular that we've all heard about. So I'll just jump into it. This is a patient whose history dates back to 2008. She was 44-year-old, premenopausal at that time, had mammography performed that suggested additional imaging, had breast MRI, showed poorly spiculated mass on screening mammogram. On the mammogram, it looked like it was mainly upper quadrant, but the MRI showed no, it's a little bit larger than that down in the lower quadrant. But decision was ultimately made to go to surgery. She had a right total mastectomy, sentinel node biopsy with free flap reconstruction, and at pathology had a 5-centimeter single focus of infiltrating lobular carcinoma, Nottingham 7 of 9, mostly classic, but there was some smattering of pleomorphic areas. Also had LCIS and ADH. No lymphovascular invasion, margins were clear, 3 sentinel nodes were negative, as would be typical for a lobular like this. The ER score, H score was pretty high, so strongly positive, PR moderately positive. And they got an Oncotype DX recurrence score that showed a score of 18, so a cumulative risk of distant disease with endocrine therapy alone. Just for saving time, this is what she received, post-mastectomy radiation therapy to the chest wall, and 3 to 3.5 years of adjuvant tamoxifen that she really, in talking with her, took it intermittently because she had irritable bowel syndrome and it just seemed to flare it. So she kept trying and coming back to it and finally stopped it because, she was relatively low risk. It just didn't work out. So at the age of 50, she was getting reconstruction, getting symmetry with the contralateral side. And as happens sometimes when they do remove the breast tissue from the opposite uninvolved side, they found LCIS and atypical lobular hyperplasia. She came back to the medical oncologist at that point, and they checked her FSH estradiol to see if she was still premenopausal. She had had a prior hysterectomy some years ago. And they decided, yep, she was. So let's try the tamoxifen again. But again, after 3 months, she just said, I just can't do this drug. So she stopped. A few years later, she developed acute appendicitis. The CT scan showed that, but and some hepatic steatosis, but certainly no evidence of metastatic disease. After she got over that, back to the medical oncologist for another discussion. And one more time, let's try the tamoxifen. But again, this time, their functional bowel had improved on cholestyramine, so they were hoping that might allow the tamoxifen, but same story. So she came off it within a few months. And at that point, she was getting out far enough, and basically what didn't continue with her medical oncologist at that time, but she was followed regularly by a PCP. And it's interesting when you look at her chart, she had chronic abdominal complaints. She had degenerative arthritis. So she was kind of living with pain. And there was always the background concern, of course, of could this be the cancer? So 2015, she had a bone scan that was negative. And several months later, when she came back to her PCP, I found documentation that tamoxifen had left that list. So I was sure she didn't take much. In October of 2020, she was in the ER with abdominal pain again, and had, again, hepatic steatosis, renal gallstones, kidney stones, but again, nothing to suggest metastatic disease as of 2020. In December of 2020, she has mammogram. And then finally, in May of 2022, we're now, what is that? Do the math. 16 years from her diagnosis. She came to the PCP. Again, my stomach's bothering, but this time I'm feeling something around my umbilicus. And I've got some shortness of breath. So this time the scans show right pleural effusion, soft tissue mass within the greater omentum, suggestive of malignancy. The CT scan of the chest then showed, you've got a fairly large right pleural effusion, but also a smaller contralateral effusion. No definite bone mets, pulmonary mediastinal nodes. Palliative diagnostic thoracentesis was positive on cytology. And the stains were positive, you can see, for showing it's breast cancer, but ER, PR were positive, and they looked at HER2 status by amplification by FISH. It was negative. Importantly, at that point, CBC, CMP were entirely normal. They did check tumor markers, and they were up a bit, but not really up that much when you think about the amount of disease that I'll show you here in a second. They also did a CT-guided core biopsy of the omental mass that showed metastatic breast cancer. So with that workup, her PCP referred her to the medical oncologist, who just referred her to me, and she recommended a PET CT scan. And these are the major findings on the scan. They describe areas of intense uptake along the large and small bowel. Index was in the sigmoid colon area. The SUV was up to 9.5. Described diffuse infiltration, thickening of the omentum, mesentery, peritoneum, inseparable from the colon, so a fair amount of disease. And incidentally, there's also something in the left breast with possibly a left axillary lymph node. They also commented on diffuse uptake in the bone marrow. And I thought I would just show the scans. Got my nuclear medicine. Is it going to go? Oh, come on. Well, anyway, too bad. There's a movie linked in there that's not showing up, but it basically shows how much volume of disease was in her bowel, and she just had her chronic symptoms, maybe really, it was more the shortness of breath that got her to the doctor than this amount of abdominal disease. So it's remarkable how much disease can get in there. So this is a point where, okay, treatment options we're delayed out pretty far, but she's got a lot of abdominal disease. So how would people treat this clearly late recurrence after a little bit of tamoxifen, and then she's now clearly postmenopausal, so we don't have that issue anymore.
Yeah, she is kind of hormone naive, late recurrences, so I would be leaning towards that.
Mm-hmm. Anybody do chemo, worrying about the extent of disease?
So I had a couple of similar patients with omental meds, peritoneal carcinomatosis. I also had some success with CK4/6 inhibitor and endocrine therapy. My patients were stable for over 2 years.
Okay.
So although we do think that these confer typically poor prognosis.
Mm-hmm. Okay. Well, the choice in this case was to try weekly paclitaxel, and the patient immediately had a pretty dramatic hypersensitivity reaction. So her oncologist was able to pivot to nab-paclitaxel. She did go ahead and when she saw the PET CT results, order imaging of the left breast to see what was going on there. And she also requested NGS be performed on the pleural fluid, which demonstrated ERB2 mutation at that point. So she felt like she needed to get therapy going before had those results back, so that she was on the paclitaxel. The interesting thing on that weekly regimen of paclitaxel, patient was quickly admitted with neutropenic fever, kind of suggesting that patchy marrow uptake may have been bone marrow infiltration.
Chuck, she wasn't under your care at that point?
No, I just saw her last week.
Given her Taxol?
No.
I would not have either. So
Yeah.
I think probably most people here would have been in the hormone therapy camp with something. Okay.
Yeah. And clearly that right choice study, I think, has really helped get rid of that idea of the visceral crisis. It's like, no, these people, the CDK4/6 inhibitors kick in just as fast as chemotherapy, and they actually do better. So there's not a reason to do that. But this was some years ago before we had right choice.
A comment on the choice there. You presented this choice. Do I use endocrine therapy? Do I use chemotherapy?
Mm-hmm.
So this is one potential utilization of that FES PET scan.
Yeah.
You have the metastatic disease that you can see on another imaging modality. You could perform an FES PET. If it's positive, it would lean you, but not guarantee you that you're going to respond to endocrine therapy. But if it's negative, then you can skip the endocrine therapy and go right to the chemotherapy. So that's where the imaging could have helped you select the next line of therapy.
If you needed it. In a case like this, where you get this natural history and the biopsy is showing ER positive, I think we're all
that's the
in
point.
this one. But
even if it's positive on the immunohistochemistry, if the FES is negative, the patients don't respond to endocrine therapy. So the whole point is that the imaging trumps the pathology.
Yeah, but the probability we can get into that. But anyway, no, I mean and I do think we have ordered that test. I do think it comes up is lobular disease, where we should not do FDG PET, but just go to the Seriana PET, FES PET. But anyway, so at that point, when they got, did I jump ahead? Did I lose my way? Yeah, I'm sorry. There we go. So she reduced the dose and got in about 3 months of chemotherapy, got the PET CT after 4 cycles, and basically had developed a liver lesion. There seemed to be more disease, so wasn't responding to the chemotherapy. So we'll just jump ahead to what she did then. She did change over to anastrozole and palbociclib. The interesting thing is the patient at that point was having some abdominal pain enough that a radiation oncology consultation was obtained, and they decided they needed to give radiation therapy to the area of the omental mass that was causing the pain. And so they started the anastrozole, attempted 12 fractions of radiation therapy. It took a month to get into 12 because of toxicity issues. So didn't tolerate it real well. At the end of radiation therapy, came in with palbociclib then. So that's kind of when the combination started. And you look, there was a bone scan done in December that was still negative. And at the end of the radiation therapy. And then, so 3 months after basically starting the CDK4/6 inhibitor, the PET-CT was showing improvement in terms of the uptake. The lesion in the dome of the liver was less prominent. The carcinomatosis lost pretty much all of its FDG uptake, and the pleural effusions were still there, but getting smaller. And the patient was clearly feeling better because she decided, hey, I'm going to get that breast imaging I was supposed to get done last year, but there was so much going on with the abdominal disease, didn't get it. So on therapy, on endocrine therapy, when she got the breast imaging, the mass was still there. It probably was smaller at 1.2 by 0.65 centimeters. They did a core biopsy, and she had developed contralateral breast cancer, which was ILC. On the endocrine therapy, on the Palbo, the Ki-67 was a little bit higher than you would like to see. So there was a question about need for local therapy. So they went back to surgeons, should this be excised? And the surgeon said, no, keep treating. So I'm assuming I would get affirmation from the surgeons on that one. So the other thing, then, so she kept going. And then in June of just a couple of months ago, got a follow-up PET-CT, and overall, everything's better. The pleural effusions are getting smaller. You no longer see the liver met. The marrow enhancement is now pretty much gone. That was there consistently on the previous studies. And the uptake that was there in the breast was no longer there. The only exception was there was a left ovarian cyst that had gotten a bit bigger and was positive on SUV. So there's this differential movement, in a sense, of the PET positive findings. So she got referred to a gynecologic oncologist who said, let's just keep an eye on that. And in August, she saw her medical oncologist. The medical oncologist said, okay, let's just keep doing what we're doing. It seems to be working. I think because we've got bilateral cancer, you were young, I'm going to get germline testing, and I'm going to refer her for a second opinion just to see what else might be done. So this is where I saw her. You know, she basically has this second cancer in the left breast that's not uptake, looks like the first one, looks like what's metastatic. She does have this enlarging ovarian cyst, and a lot of that mass is just cyst that's active on PET scan, but very little else on PET scan. So the questions were, what else might we do? Do I need to be doing anything else right now? Not so much what should I switch therapies, but sort of anticipating what's next.
So Chuck, mindful that Jeffy is beginning to look at me about the clock, what did you recommend? And then we'll see if we like it or not.
Okay. So I said, keep doing what you're doing. The serial PET scan seems to be working, though I suggested getting a FES PET just to see what the ovary would do, and also to see, is the bone marrow, is there really disease in the bone marrow? Because it's sort of back there in the background. Not really essential at this point, but the insurance company did approve it. So I don't have the result back yet, because I just kind of want to know for sure what the bone marrow is. And then we have sent blood for ctDNA, CTC analysis, just to kind of see where things are. And looking ahead, I said I would probably be moving over to take advantage of the mutation that was found in her too, with maybe neratinib, but since she already has the functional bowel thing, this might be one where I would try and do tucatinib just for a tolerance issue. And I would make my choice between switching to a different AI or putting her on fulvestrant based on, do I have any ESR mutations in my testing, kind of those sort of things.
And first, how's she feeling? And then Rita has something to say.
Oh, she feels fine. I mean, this is all asymptomatic stuff. Unlike last year where she was having a lot of symptoms, she's clearly responded.
I just wanted to ask about when she was not tolerating the tamoxifen and had this sort of diagnosis of IBS.
Mhm.
So it sounds like her GI disease is serosal, not mucosal. So something like a colonoscopy may not have found it. But I think given the number of reports and people's clinical experience, I'm curious to know, I would have thought maybe she should have had a colonoscopy and a conversation with a gastroenterologist about even taking random biopsies in someone with a history of lobular breast cancer and persistent diarrhea.
Okay. Yeah. She had a gastroenterologist was managing that for her. I honestly didn't think to go looking to see if they had done scoping way back then, but it's a very good point. I mean, it's a little unusual to have the diarrhea from tamoxifen, but it would stop or at least go back to baseline when they'd stop it. So it was hard to, particularly after it's happened 3 times, hard to argue with her.
Well,
and she would improve on cholestyramine.
Thanks very much. Very, very complicated course. I'm glad the patient's feeling well, and it sounds like she got really good advice. So with that, let me bring our session to a close. Thanks to all our panelists for really fantastic presentations, and to all of you for participating in the dialogue. Steffi.
Thank you very much. This was really, really outstanding. Thanks. Now I realize this is the very end of the symposium. I think in the schedule, we have a discussion of potential for collaborations and how we want to move forward for. We'll go ahead with that, but promise we will keep that short. So I would like to invite Patrick and Anne and Claire and let me see, where are you? But Jason, whoever I discuss this with, can you just come forward?
The line between lobular breast cancer and all other breast cancers is not necessarily so rigid either. And I just remember, like, back in the day, we used to take organs out of a mouse and just grind them up and look at RNA as if all the cells in that organ were the same. Now we live in the world of single cell analysis where people have to deal with a huge amount of data, and you see that an organ may have 100 different cell types. And so will we see in the future not just lobular breast cancer meetings and ductal breast cancer meetings or general breast cancer meetings, but will there be meetings that are based not on pathology, which this is, but on MLL3 mutant breast cancer meetings or chromosome 17p loss breast cancer meetings, because there's going to be similarities amongst all of those different groupings that will be beneficial. And there's going to be instances where we want to get together with people working with different pathologies.
That's a fabulous question. I think there was already like a ROS1 meeting, for example, a pan cancer, and I think there might be others. I don't know if anybody wants to comment on this quickly. Great. It's a great idea, Sean. I think definitely. And like I said, there are some examples, and I'm sure it's going to expand. I think maybe we can have an Iketerin meeting, right? Yeah. So anyway, we will try to keep this short, but I do think it is important. And thank you very much for joining me. I think the goal is maybe to quickly, everyone, to discuss what you think you have identified areas for where we should really focus on, maybe areas for collaborations. I think it would be good maybe if there are also, comments from the audience. I have Laurie and Claire here who oversaw a lot of the GlobMorg activities and preparation for the meeting. Maybe you guys can comment on this as well. I don't know, maybe I'm going to start with Patrick with the basic biology. I also know that Patrick has to run and catch a flight at some point. So anyway, Patrick, maybe you can start.
Okay, yeah, that's good. I think this nicely hinges towards what we did with the ELBCC as well. We had some brainstorm sessions on what are the priorities and from a biological point of view, but also from a clinical point of view, what is important, and maybe Anne can comment on the clinical ones. From a biology point of view, I think one of the main things was the connection between dormancy and awakening. We more and more understand why these cells do not divide as fast as other cancers, but we still don't understand what causes these long latency relapses, and that is a real problem within the disease. And I think we've made some headway in our group and other groups that we understand why they don't divide anymore. And I think one of the priorities is to come up with models that actually push cells into dormancy so that you can actually study awakening, which is now a real problem. Now we have to transplant cells and just wait and see and get lucky. And it might be really good to have systems whereby you can actively manipulate the cell to go into dormancy and see what awakens it after a long time, either in the lab or in a mouse. And I think that's one of the key priorities within the biological field within ILC.
Yeah, great point. And did you want to say something?
Just to go on with diagnosis issues, I think that's the major issue of progress, both at the radiological level. I think that we all heard about insufficient sensitivity or accuracy of mammography. So maybe physics may help medicine to improve radiology diagnostic assessment for lobulars. And from then after, for pathologists, you understood that a lot has to be done again in standardization of what are really lobular, what are mixed ductal and lobular, what are the subtypes of lobular, do they matter, and how can we improve the way we diagnose these issues, and then how we can better define the prognosis at the pathological level and using molecular tools. So that's, I think, from my perspective, what matters.
Yeah, I think that's great. And I think thinking of the next meeting already, right, to the idea of dormancy, but the idea of diagnosis and maybe including a session really on AI, maybe in a year from now, we'll be even further, right? Yes, please.
Hi, I think from a patient's perspective, it picks up on both of those from kind of both ends of the spectrum from imaging in terms of improved diagnostics. It's because obviously it's a clear worry for patients. And from the other end of the scale, in terms of dormancy, most of us have monitoring that's kind of quite a short time frame, the 5-year, potentially 10-year, but we know that the dormancy is a clear worry for us as patients as well, and how we are monitored going forward, and what are the best techniques, whether it's through imaging, liquid biopsies, and so that real understanding of why lobular goes into dormancy, but how we in a clinical setting can be monitored to take that into account.
Yeah, absolutely. Fabulous. Jason, do you want to?
Yes, definitely. I think about this meeting was great. It gave me lots of great ideas. I'm really interested in the part where it's the translational portion, what I can take from the lab to the clinic. There was a lot of ideas thrown in. I'm gonna mention them real briefly. Number one, when they presented the combination of CDK4/6 inhibitor plus AKT inhibitor, that's very attractive, should be pursued in lobular. So that's one idea that should be pursued. The other one is use of PARP inhibitors. So I heard multiple talks, and definitely Matt's lab working on that, looking at PARP inhibitor, regardless of having a BRCA1, BRCA2, PALB2 mutation, just having a signature, HRD signature, that's very attractive and should be pursued. We already had some idea of some collaboration with multiple centers to do that. Also, looking at immunotherapy. Again, we have showed and others have showed that some subtypes of ILC are immune enriched, and those patients should be looked at for benefit from immunotherapy in combination with a targeted therapy. Otherwise, also there is the emergence of ROS1 inhibitors. I know we don't have a US study yet, but we are working hard with other people to open 1 or 2 studies here in the US to look at ROS1 inhibitors in metastatic ILC. And finally, I'm very happy that they're bringing, yes, HER2 mutation is common and more common in ILC, and I'm glad that they are bringing it to the early stage. This is what was presented by TUT Southwestern, that they are gonna look at doing AI and neoadjuvant endocrine therapy plus neratinib for patients who have an ERBB2 mutation, which is excellent.
Great, thank you so much, Jason. Claire, do you wanna? I'm sorry. I was mixing up. Laurie, do you wanna?
I was really pleased with the workshops that the patient advocates did and the participation of the clinicians with them. And it made me think that it's something that I'd certainly like to see carry forward. And that there were some topics that came up that I think would be great to have patients integrated in some of the panels. Like today, I was kind of impressed. Somebody had mentioned to me earlier about, why don't we ever talk about lymphedema? And I said, that's kind of a breast cancer general conference. But then when we had the presentations today about the imaging and the issues with lymphedema and how it's more particular in lobular, I think that's a really great opportunity there to integrate a patient into a panel that deals with some of those issues. So more things like that. Was very pleased.
Side effects, yeah, that's right. Yes. I think these are all great points, great ideas for the next meeting. I think one thing which floors me a little bit is that how little is done on imaging, right? I mean, there is not much research done on imaging. It's so obvious.
It's physics.
Yeah.
Medicine, it improves a lot.
Yeah. Or just other tracers, or I don't know. It's just not much done. Yeah. I'm sure there's going to be lots of suggestions from the audience, right? There we go. I knew I could rely on you, Siobhan.
Rita, we didn't hear from Rita yet.
So look, congratulations. It's been mind blowing, it really has. But please take Steffi's comments there on board going forward and include an imaging specialist like Matt that we have here. If I could ship him over with me, he'd be coming with me. But, we really got to get on board this because we're being diagnosed at late stage. We have complications, axillary node clearance, we have lymphedema, we have all these issues, whereas we could avoid an awful lot of those. Quality of life really, really matters. And if we can get on top of it earlier, that's what we want.
Yeah, and before I come back to the audience, I really wanted to give the breast surgeon the last word.
I think I've spoken enough, but I think I would just echo, I agree that one of the major challenges is with disease assessment related to imaging, both at the level of screening and diagnosis. I think it's also related to disease assessment, both in the metastatic setting and in the neoadjuvant setting. So early endpoints of response to therapy, which I think would facilitate understanding whether or not these targeted therapies that Dr. Moabi was talking about are effective specifically in ILC. So I think developing those ways of determining how extensive is the tumor, where is the tumor, is the tumor actually responding to therapy as we would want?
Yeah, I think that's great. I think these are all great comments. I do think we learned throughout the symposium that a lot of it has made progress. And for example, I think we have better models now, but some of it we still just lack data, right? I'm so excited about all the liquid biopsy stuff, right? The CTC, the ctDNA, there's more there, but I think we just don't have in the sufficient N to actually make conclusions on this. Margaret.
Yeah, I think when we're talking about collaboration, meetings like this really need to include the pharma and the payers and the FDA, because all the discoveries and the translation that is shared during this meeting and continues is not going to benefit patients if they don't have access to it. And so we've got to get them in the room.
Yeah, absolutely. I think that's totally, and I come to you in a second. Yes, Matt, and then to your left, and then Thijs.
So the question about the standardizing diagnosis of ILC, you made the comment about AI and seeing where that goes, but ultimately the AI is still informed by what we decide is ILC up front. So is it our job to decide that it is histology plus ECAD status plus P120? I mean, Patrick, your data on those alpha-ketene mutations, the comment about, is that a different molecular disease? I mean, that I think we have to consider that in what we're defining is ILC. So is it this meeting that we need to decide what we all say ILC is so we can all move forward with the same tumors?
Well, the papers are coming out. So we're working together in Europe and also with the Americans to come up with a harmonization, or at least a sort of agreement on what we call ILC. And I think the paper will come out in any of these months. And it's, I think, relatively simply based on histology primarily, and then an ECAD in combination with the immunohistochemistry.
Yes.
And that should be the primers, and then try to focus on the subtypes. But that's a later worry.
Yeah.
Fabulous.
And the standardization of the workout, we worked on that with the group of the European pathologists plus American pathologists, and to try to figure out if E-cadherin is positive, it's positive, but decreased expression, abnormal expression. So what's next after observation like this, and to go for P120 and beta-catenin, but to go really into details on a practical way, because then us as breast pathologists, we can figure out how to do. But the most important is that a large community of pathologists agree and can use it, affordable everywhere in the world if we want to make a progress. So E-cadherin mutations, yes or no, and etc. This will come, and this is ongoing. Yes, really.
I mean, that's fabulous, because that's when we all go back to our institutions and we need to query our banks and get the equivalent of the centralized review with your criteria, then we can. That's awesome.
Yeah, Ahmed, I think that's a really good question, right? What's the ultimate truth? I think these studies are brilliant. I still think I would love to know if there's a different precursor cell. Is the lineage actually different? Maybe transcriptomics and genomics on its own might not be sufficient. Maybe we need to look at epigenetic changes as well to really define, maybe it's a different lineage, right? It's like such a basic question we haven't answered, Yes, please.
So I'm a patient and a brand new advocate. And I really thank you I feel like I'm in the brain center of the work, and it's really wonderful. But the entire week I've been highly aware that I live in the left armpit, and that by virtue of not living here or in London or in Boston, I will have a shorter life. Like, that just feels really clear to me. And so I just want to say there are a lot of voices missing, but the one that you maybe have the most power to, I'll do my best to do everything I can and enroll people and do whatever, but my doctors are not bad people, but they really aren't giving me the latest info. They are really like, oh, it's menopause. Oh, wait, it isn't. Oh, what would we do? Why get a biomarker? What would we do different? What would we even do? And I'm like, I have to figure it out. What? And I think that I want to point out in terms of access, am I supposed to move to Boston? I don't really know what my plan is, because I don't feel like this amazing, challenging information I really appreciate just doesn't get there. They can't afford to come to conferences all the time in the rural areas. They don't know. And I don't know what that system, I don't know how that gets fixed. I really don't.
So, I mean, I just want to start with saying thank you so much for being here. I think we really appreciate, we need people like you here, and maybe I can give it over to a physician.
What you talk about is really hard, and I'm sorry. And it is difficult to take care of a patient from afar, if not impossible. So you have to have a primary oncologist at home who sort of takes ownership over your case. But there are a lot of patients who will sort of do a joint strategy where they check in with one of us, at an academic center several times a year, or at the time of progression when they have scans. And what we try to tell people is, don't jump to the next treatment until you talk to us first. It's usually not an emergency. It always feels like an emergency when your scans change, but we'll be happy to, kind of collaborate with your local oncologist or give them some advice. I mean, I always try to give my phone number to the local oncologist so they can call me when the change happens, things like that. But I'm sorry you're going through that, but yeah.
Yeah, just to add to what Rachel is saying there, I think one suggestion that I make to folks, and if you're in a really rural area, I don't know if we're talking Montana or where you're talking about, but I grew up in Texas. My family is rural. I started out as a community oncologist, and but the thing that I had to do was participate in clinical trials at least. I didn't feel like I was smart enough to design them, but I knew I wanted them available to my patients. And there's there's three types of oncologists. There's the academic types that are in the big centers. Then there's the community types, and there's two types. The ones that are participating in clinical research will be more up on things because of their trial, and they develop the social relationships with the thought leaders, the academic people, through these NCI funded groups. The NCI right now is putting a big emphasis on underserved rural populations right now, because there's been this progression of defining underserved, by race, ethnicity, but it's like, hey, and they're now starting to fund these community oncology research programs focused on those things. So there are places, and my research group, the NSABP, works a lot with community doctors. So I know there are doctors. It's hard to find a state that doesn't have somebody participating in NCI trials. Just a suggestion to think about that, to get to that different subtype of doctor, possibly.
Thank you. You have one question there or comment?
Thank you. I'm a patient 5 years ago for treatment. I'm repeating the need for, I'm making two comments, repeating the need for early detection, whatever tools we can use for that, because it snowballs. For example, I'm now dealing with heart issues directly from my treatment from chemotherapy, which was a surprise. And I have to admit, I was going, just like when my first was diagnosed with lobular after regular mammograms for over 12 years of saying, what's this? And all of a sudden I asked, well, why didn't you suggest an MRI? And they said, well, we didn't think you wanted to pay for it. So the education is important, but early detection, it can snowball. So I'm looking at a pacemaker with a completely healthy heart, except for the LBBB, which was diagnosed 4 years ago at MD Anderson. There should have been some kind of red flag at that point. But this is, early detection. You don't get the snowball. The second comment, I am not medically trained. I am logically trained. Won't go into that completely. Physics, medical, there's a logic of how you set up an experiment. I do not see a null hypothesis. Dr. Olener pointed it out. You do not go just on the probability. You have to eliminate the improbable. That's the only way you're going to find a personal approach to each unique human. If you go with statistically that is not probable and dismiss it, that's not null hypothesis. And these are old words. Null hypothesis is important. You have to eliminate the improbable. That's the only way, one, you can distinguish one individual from another, and you can make sure you're not letting lobular cancer be ductal cancer forever. Ductal cancer is the probability. The null hypothesis that this whole thing has moved on is lobular cancer. We found the null. And now we are finding personalized medicine that it's just 10, 15% of cancer. It's what? Less than 1% of the general population. This whole group knows how important the null is. So when you put your studies together, always eliminate the improbable. When you're looking at a patient's clinical presentation, eliminate the improbable, because if it becomes positive as an FES scan, one way or the other, you know something about the direction of that patient. If you do not pursue the elimination of the improbable, you will not go forward and you will not find new ways to do it. And just the third comment is that I was surprised that my mother was treated with chemotherapy in the 1980s, late stage. I got the same menu. I do not see a progression looking outside in, and that dismays me completely. Thank you.
Very much. Thank you very much. There in the back.
Yeah, I have a question. So before I came to the convention, I had read something about a cancer vaccination. And during this whole talk for the few days, I had heard mention of mRNA. And I had not heard anybody bring up cancer vaccination. So I just wondered, is that something that's in the pipeline or why it's not mentioned?
That was very kind. Yeah, it is unfortunately an area. Obviously, I think prevention would be the best. If people didn't get cancer, that would obviously be optimal. Vaccines have been very hard to develop, but there have been great advances. We have a vaccine trial that just opened here, just in the last month, which targets a protein called MUC1, which is very common in breast cancer. And so patients are given a vaccine to see if they can develop antibodies to that and hopefully eliminate that. And so that trial is just ongoing. The company BioNTech that developed the COVID vaccine with the mRNA, like you said, before they did that, they were developing lots of vaccines for clinical trial for cancer patients. Those are in late phase 3 clinical trials, and the early clinical trials showed success. So there's a lot of excitement in this, particularly, for instance, for HER2 positive breast cancer. I think there'll be meetings only on cancer vaccines happening at the moment. There isn't a lot happening in ILC, but I'm sure there will be.
May I quickly, I wanted to reference back to the comment about rural areas. And I'm from Fairbanks, Alaska. Dr. Moabi is my doctor who I work with now, and I work with in conjunction with my local clinic. And I feel like us as patients and as advocates, we play a role in this as well by talking about our story and about talking about ILC and making more people aware of it. I often will talk about, I'm 14 months in this journey, and I'll talk about my ILC diagnosis, and I'll encourage people, of course, for mammograms and early detection, but also encourage them, if they hear of people or if they are diagnosed with ILC, to to investigate that. What does that look like? And to ask their doctors. And then for me, that led me to Dr. Moabi, who, after going to several different doctors, spoke a language that made absolute sense to me within, the first 15 minutes. And my mom was with me. She felt the same way, and then gave us a very clear path forward based on research. Whereas before that, all of the information I'd been given was very much like, here's a menu of all these things and you can choose. You realize as you're diagnosed with cancer that you become your own best advocate, but there's a very steep learning curve. And by connecting with experts and with organizations that advocate for you, you can make some big steps. So I'm a big proponent of reaching out to those experts and bringing them into your corner. And I think there can be some partnerships even in rural areas that happen, but also want to advocate for sharing all of your stories. Talk about ILC. That's how awareness is raised.
Great, thank you. We have Thijs and then in the back. And then I think Thijs, please.
So two on the discovery-based science aspect. So what we haven't covered, and I'm not sure we should, but maybe we should think about it, is the extracellular matrix, and especially how it translates to the interface in the breast, but also why cells are colonizing and growing up at these specific metastatic sites. So there must be signals in and out provided by the ECM, what makes them to grow. And I feel we should maybe get a sense of that. And then more in the terms of explorative therapy, cell-based immunotherapy. And I think this can be in particular interesting for lobular cancer because these are solitary cells, and it's not like a tumor mass that needs to be cleared, but single cells indolent floating around in the body that can be targeted with such therapies. Just from the
great comment. Thank you. And now,
hi, I'm a patient and advocate. First time here. I want to thank all the scientists and doctors that came, and also all the advocates. It's great to have everybody in a room. It feels fantastic. One of the things that at the beginning of my diagnosis, the LBCA's website was amazing. And I've gone up to a bunch of the people who've been part of making videos, and having those up there for patients to find whenever they get diagnosed is terrific. So please, thank you so much for that. I was curious for people who have questions, like patients, we're getting these treatments, we're having these things, and they're going to keep developing. And researchers and doctors need to know what our concerns are and how the rubber actually meets the road. Is there a place, or could we create a space other than this where patients could explain to people, researchers, doctors, how it's actually working or what the concerns are as it moves forward? So it's not just, this once a year thing, just so that if you're wondering about it, you can kind of see how it's actually working in the real world for patients. And thank you again.
Yeah, no, these are really, really great comments. I think we will, after the meetings, we'll get together, and some of those comments, I think we will try to address it as a team and maybe think what we can do in real life to address them. And there's a lot happening already with respect to, workshop, webinars, websites, but I do think we can do more. I think I really, really appreciate this. So this is, I told Julia, the last comment. Very, very, very brief, very brief.
Okay, I'll be very brief. There are two things that stood out to me. One is that diffusion weighted MRI available in Europe should be available here. And I hope that institutions will take it upon themselves to get it, work with insurance companies, because it's obvious that it can be another good imaging tool. The other thing that stood out to me was the CTCs, which are already covered by insurance. So why not be using them? Thank you very much.
So I think that I am going to close it off. Just to say again, thank you to all of you for coming. I just texted Nadine, who was always on the registration. Oh, here they are. Here they are. Oh my gosh. There we go. There we go. Look at her. Look at you guys, right? How are you? So I should tell you that obviously it's those folks who did it. I really appreciate you guys clapping and standing up, because none of us are professional meeting organizers, right? This is all done on the side. So this was a lot of effort, and I really can't thank you guys enough. And yeah, for all the efforts, for the many, many hours, weeks, the time you put into this, really, really appreciate. And I appreciate you guys for appreciating it. So anyway, have a safe trip home. Yeah. Take care. Bye-bye.